Well, good morning, everyone. We are now ready to start our June meeting of the Texas Child Mental Health Care Consortium. So again, appreciate all of you finding time in your busy lives in the middle of the summer, et cetera, to be part of this. We have a very full agenda. There's lots of things that we need to go through today related to updates of the projects, the budgets, the legislative session, and hear the good work that's going on in your institutions. And so we're going to go ahead and get started right away. And with that, Luann, I'm going to have you call the attendance.
Okay, Dr. Leahy.
I'm here.
Dr. Goodman.
I'm here too.
Dr. Williams.
Ditto.
Dr. Liberzon. Dr. Harper.
Present.
Dr. Wakefield.
Here.
Dr. Trevino.
Here.
Dr. Thompson.
He will be joining shortly.
Okay, Dr. Martin.
Here.
Dr. Podewils. Dr. Chasse.
Here.
Dr. Nemiroff.
Here.
Dr. Strakowski. Dr. Tan. Dr. Rob. Dr. Wagner.
Here.
Dr. Vo. Dr. Suarez. Dr. Pliska.
Here.
Dr. Blader.
Here.
Dr. Escamilla.
Here.
Mr. Patriarca.
Here.
Dr. Bryant.
Here.
Miss Nichols.
Here.
Dr. Taminga.
Here.
Dr. Ibrahim.
Here.
Mr. Maples. Ms. Gaines.
Hey, how are you?
Good. How are you?
Good. Am I early or something?
No, you're all good. We started.
Okay.
Ms. Silverman.
Here.
Sorry, I think that's doctor.
All good.
Okay. Dr. Martinez.
Morning, Luann. Here.
Good morning. Dr. Keller. Ms. Castle. Dr. Wesley.
Here.
Dr. Borges. Okay. Thank you. Is there anyone that has joined that I did not call?
Yes, this is Israel Lieberson from Tamu.
Okay. Thank you.
Eric Storch from Baylor.
Okay. Thank you.
Luann, this is Shannon Gangerty. I'm on for Andy today.
Okay. Thank you. All right.
Very good. I think we're at 22. We have 22 members here for my count, and so we have a quorum, so we can go ahead and move forward. So again, appreciate everyone taking time out of your busy schedule on this day and being part of this meeting. Why don't we start with the legislative update? I'll kick it off, and then Sean Griffin, who heads the UT system government relations work for Office of Health Affairs, will then jump in. But and I'm going to focus in on just the efforts of the consortium and the funding of the consortium. The good news, folks, is that it is official. We received $118.5 million over the next 2 years to improve the care of children with mental health care needs here in the state of Texas. I have shared the rider with everyone and the executive committee, but the rider is very directive related to, which is good, related to how those funds will be spent. For CPAN, we have been allocated $15.8 million per year for CPAN efforts. For TCHAT, about $25.3 million per year. For our CPWE, just under $7 million per year. For our CAP fellowships, $4.1 million per year. For the research project, $5 million per year. That's the Central Operating Support Hub, $1.135 million per year. For external evaluation, $375,000 per year, and the administrative budget is still at $600,000 per year. And so we are very pleased. There is guidance in the rider related to the ability to transfer dollars as needed, 10% between those projects. If we need to do more, that's possible if we go to the LBB and we seek their approval. And we have the ability between year one, which will be year 3 for the consortium, and year 4 to be able to move unexpended balances from one year of the biennium to the other. And so basically they put in what we requested. And again, deep thanks to Senator Nelson and her office and Dr. Bonin on his side for supporting the Texas Child Mental Health Care Consortium. And thanks to everyone around this virtual table here for all the work that you did to make it possible. So the legislature felt comfortable putting in the additional money to keep you whole over the next several years of the biennium. There are also good news for other activities for the consortium. Steve Pliska, I'm sure you're pleased that San Antonio State Hospital has received the funds to complete that effort, and thanks for all the work that you're doing with that. Charlie and Emeroff, same thing for Dell Medical School and the partnership with Austin State Hospital, all the funds to complete that. And I was encouraged driving down Lamar today just to see the buildings that are being put up. And so a lot of great work there. And Carol, I know up in Dallas, funds were put in to start the process of trying to bring a state mental health hospital to the last major metropolitan area of Texas that doesn't have a state run mental health hospital. And there's other planning dollars in other parts of the state. And so I think for the things that we've been really deeply involved in, thank you all for all that work, and thank you to the legislature for their support. With that, Sean, I know you're on the line. Let me hand off to you to see if there's things you want to update the consortium on.
Sure. Thanks, Dr. Leakey. Good morning, y'all. I'm sort of keeping in the vein of mental health, which is obviously our focus here. There's a couple bills that we may see some sort of participation in to some degree. One bill creates a suicide prevention subcommittee at the statewide behavioral health coordinating council. So I'm sure we'll be hearing from Sonia on that one. They're going to be collecting information from public and private sources and incorporating strategies into their 5-year plan. So perhaps there'll be a way for some of our activities and programs to help participate in that effort. There also is another bill that is going to require HHSC to conduct electronic health records and technology interoperability study. They're not going to look at you all specifically as providers. It's really focused on the state hospitals, the LMHAs, the freestanding psych hospitals, and some large Medicaid providers. But it's going to ostensibly formulate some recommendations for the next legislature about how aligning electronic health records and technology in order to share information about patients as they move from setting to setting to help improve basically our overall infrastructure there. So we may see some of that activity come our way. Moving a little bit off of mental health specifically, but sort of just for your general knowledge, telemed obviously had a pretty good session this year after the pandemic and all the experiences we've had with it. The ball moved forward pretty significantly in a couple of respects. HB4 was the sort of omnibus Medicaid telemed bill, and it made permanent all of the temporary provisions that were put in place for the pandemic. So that's more of a, from here on out and in the future, telemed is going to be reimbursed on Medicaid. And also HB 1616, this had Texas join the Interstate Medical Licensure Compact. I think we're like maybe the 38th or 39th or something like that states to now have joined. So we'll be able to use that process to offer, and this is obviously in the scale of telemed because we're not going to be flying to state to do care, but now it'll be a lot easier to treat patients in other states. Looking forward, you probably have heard some scuttlebutt about special sessions. We are likely going to have at least two. One will be sooner than later, maybe sometime in mid-July called, or if they really want to be sneaky about it, maybe August 1st. This is going to pick up some of the red meat issues after the election bill failed at the very end of session. Governor Abbott promised to call lawmakers back to retry that one. He may or may not veto a part of the budget that funds the legislature and associated agencies in order to hold everyone's feet to the fire and get it done before September 1st. We'll find that out today, perhaps, maybe tomorrow. He has until Sunday to veto or sign legislation. And typically in the cycle, it's usually today, tomorrow, sometimes yesterday. But these 3 days are when you start seeing a big dump of, dozens of bills that have been vetoed. And we may find out exactly what they'll decide to do with the budget. But either way, he's going to be adding that to the call sooner or later, and then we'll have to come back in October is the best guess to do a redistricting special session to redraw all the political maps once the data is in from the Census Bureau. That at any point too, in any of these, he can add other issues to the call as he sees fit. We are expecting to get a shot at some federal stimulus funds from the pandemic relief. I think there's supposed to be $16 billion of federal funds under consideration for use mostly in health settings. And that the best guess is that'll come in that second special session of redistricting, but really we don't know exactly when, but it'll be sometime this year, and we'll have some more information as we get closer and see the parameters of that. If there are any opportunities for the consortium to participate, I'm sure we'll let you all know. So that's kind of the broad strokes and some of the highlights. I'm happy to take any questions if there's anything else that you all had heard about that want to know more on, or anything I covered you have some questions about.
Are there any questions from the executive committee?
I did an excellent job then. Thank you, guys.
Perfect job, Sean. So let me jump back a little bit. I quickly went into the legislative session, but I failed to make sure that we approved the minutes of the last meeting. And so let me jump back, and I think everyone has had a chance to look at the minutes. Any comments, any corrections or changes?
Move to approve.
I have a motion to approve from Dr. Liverson.
Second.
Second from Dr. Taminga. Any further conversation? Hearing none, all in favor of approving the minutes from the last meeting, signify by saying aye.
Aye.
Any opposed? Say nay. Are there anybody abstaining? Hearing none, the minutes are approved unanimously from the last meeting. Let's now go to section 4 of the agenda, the updates of several activities. Let's start off with the program evaluation. Dr. Lopez, the internal evaluation.
Good morning, everyone. This is David Lynch from the internal evaluation team. Dr. Lopez cannot make it this morning, so I'll be giving our brief update on particularly one of the projects we're working on. Once we can get the slides up here, I'll walk through them. Just to recap a little bit, back in January, Dr. Lopez gave a kind of what we call a snapshot look at the initial data from CPAN experience surveys that were sent out to enrollees and users of CPAN consultation. And so what we're doing here is kind of a similar thing with the TChat experience surveys. So if we can get the slides up here.
Are they not up?
I'm not seeing them.
Luann, what we see is the list of all the items from this meeting.
Oh, shoot. Okay.
The presentation itself is not on the screen.
Huh. Okay. I'm not sure why, because it's on mine and it says I'm sharing. So let me see.
You may be sharing the wrong screen. Sometimes that happens to me.
Huh.
I can see you moving your mouse around.
Let's try this.
Luann, I would stop sharing and try sharing again and make sure you choose the PowerPoint and not your desktop.
Okay. Obviously, I am techno challenged. Let me see here.
We're good.
Okay. Now is it showing?
There we go.
Yes. And if you could make this a little bigger on the screen, that'd be great.
Oh, boy.
Okay,
Okay.
just go to slideshow and begin from the beginning.
Yeah, slideshow would be good.
Yeah, not that way.
Yeah.
Slideshow.
The next icon, that icon right there. Click that.
Ooh, now it's huge.
Thank you.
There we go.
So there's a cover, just to give you some background on what we're looking at here. Just a snapshot of some of the experience survey data from TChat. If you can go to the next slide, please. And this just provides some background. I'm not going to read all this. I know we have a really packed agenda today, so I'm going to kind of walk through this relatively quickly, but it's pretty straightforward. Just to give some background on the particular instruments we administer to the HRIs to in turn send out to the TChat users, both the students from 6th grade up and as well as the family members. In this, you can see that we sent it out in March, and so ever since mid-March or so, we've been collecting these data. The respondents send the information via anonymous web link or on their mobile app. It goes right to us directly. We process the information and provide summary reports to the HRIs each month that shows their values for that month as well as the year to date, and then it also shows the state comparison for the month and the year to date. And the third bullet down there, I want to highlight, we've done some translations. We've done Spanish and Farsi, and we're working on a Vietnamese one right now. And what I'm going to show you, these next two slides are just kind of some of the summary data for the state. So if you can go to the next slide, please, Luann.
If you press your right arrow button, Luann, it'll go to the next slide. On your keyboard, the right arrow.
Yes, I'm doing that, and unfortunately, it's not doing it. Oh, dear. Let me see. Sorry, guys. I'm usually not the person that does this, obviously.
Okay.
If you want me to, if you want to stop sharing, I can try sharing.
Okay, thank you.
Right. Let's see.
Great,
All
thanks.
right.
Okay, so this is just, like I said, a broad overview of the state data to date. And a few of the general caveats on here, we're not looking at a large sample size. So if you see the ends underneath the student and family are 22 and 45, those are the number of surveys we've gotten in since this time. And I have underneath there the number of HRIs that are represented. So we're looking at half the HRIs for students and 2/3 for the family, which is, it's not, we want 100%, but that's still pretty good considering we just started. And then you can see the gender breakouts and race, ethnicity, and grade. It's kind of FYI, I don't see anything that really pops out as unusual or unexpected. You can see it trends female. And of course, under the grades, you see that there's no values for the student under 6th grade because they don't get the survey, but the parents do. So there's some overview there. The next ones have a little bit more meat on them as far as something that might be interesting. These are some of the questions themselves about the experience the respondents submitted. And the way this is set up is that there's the selected questions that are parallel on both surveys. So the first one, it says, I am satisfied with TChat services. That's the student version. And then the parents' cognate is, I am satisfied with my child's services. So we just kind of put those together so you can see. And then there's a Likert scale 1 through 5. And we converted that to a numeric value. So again, the caveat is it's a small sample and it's preliminary. That said, if you look at these averages, I think they're overwhelmingly positive. Meaning, if we saw these numbers to be an average of 3, that would be basically everybody in total would be an average of unsure or not really strongly opinionated either way. But you can see all of these percentages or these averages are below 2. So that's strongly agree, depending on what the particular number is. So I think that's really good overall. And again, I'm not going to read all the questions here. I see one of them kind of got cut off there, but these are all right from the survey. And if anybody wants any of the actual survey instruments, happy to provide that or any other information about it. But I do want to call folks' attention to the bottom question there. So this is the, as a result of TChat services, I am doing better, doing worse, doing the same and things. And again, it's a Likert scale. So you see the values there, 1.6 for the student, 1.7 for the family. Again, very, very good, average, very much in the doing better. But if you break it out into the percentages response for each of those 5 values, you see that there's a 91% of the students are reporting doing better in some fashion, and then 85% of the parents are responding that too. And I think that's really encouraging. Again, preliminary information early on, not a big sample, but still a very good signal we're getting from some of the respondents and their experience with the service. And so the last page there is just, we also have a qualitative section where folks can respond, just free text. And these are not all the comments. There's dozens and dozens of comments. And there are some ones that are probably, that are a little bit more targeted for opportunities improvement, some less than fully satisfied responses, but those were sent, all the responses for a particular HRI are sent to them every month. So they all have those so they can work on quality improvement and things. But these just are some of the ones that are about the statewide kind of program overall. And as you can see, the last one there, we got some responses in Spanish and translated them. But as you can see, the majority of the comments are very, very positive. I want to call your attention to the third one there about the number of appointments. That's the only one we've received so far, but that is some input there about the number of appointments. Anecdotal right now, just kind of, one person's response, but I thought it'd be good to highlight that. But again, this is just a quick snapshot on one of the instruments we're administering to one of the programs. Again, if anybody has any questions about any of the particular data or the instruments, please feel to reach out. Otherwise, thanks again for your time, and move on to the next agenda item.
Very good. I see Dr. Octavio Martinez's hand up. Octavio?
Thank you, David. Just a quick comment. David, thanks for the info. Great presentation. I know it's a small cohort right now, but what I thought was really encouraging, one, the movement toward increasing the surveying language with Vietnamese coming on board. 2, overwhelmingly, though I know it's small, I think it was only 22, the recipients of the service, the students themselves, the children, are actually see the services much better than the parents do. It's probably not statistically significant yet because obviously it's too small a sample. And then third, I just wanted to point out that I really like the fact that both parents and the kiddos are saying they were treated with great respect. Given the timber and how things have gone due to the pandemic, I think that is just super valuable. Anyway, thank you, David.
Yeah, great. And I noticed as well that generally the students tend to have a little bit more positive response, but yeah, you're right. It's minor. So we'll track these data over time and see how it progresses, and then we'll get a better sample size to run some other statistics maybe on it, or just feel a little bit better about what we're looking at. But yeah. Any other questions?
All right. Well, thank you, David.
Great.
Really
Thank you.
appreciate it.
Yep. Pleasure.
And then one little logistical thing. I see that Dr. Thompson from Texas Tech El Paso has joined, Dr. Suarez from UT Health Science Center in Houston, Dr. Beverly Bryant from UT Health Science Center in Tyler. Are there any other executive committee members that have joined us since we started? Okay, very good. Well, why don't we go ahead then to item B under 4, the external evaluation. Dr. Savas and Dr. Peskin?
Yes, hi.
Hello, we can hear you. Good to have you
Okay,
here.
great. Great to be here. So we also have a pretty quick update. We're still really in the midst of all of our data collection activities, but we wanted to just provide a quick update of where we are. So next slide. So we've talked about this in the past, but we've really made a lot of headway with these process mapping interviews. Just as a reminder, we created interview guides for all of the HRIs, CPN clinics, and TChat school districts, and we've been conducting interviews with key stakeholders from each HRI and also a diverse sample from 12 CPN clinics and 12 TChat school districts, making sure that we have representation from one school district or clinic from each HRI. And just as a reminder, the process maps are really helping to provide a baseline of current practices for participating HRIs, clinics, and school districts. And so what we're producing is really these detailed flow charts of really how TChat and CPN are working across all of the different entities. So far, we've completed 24 out of 24 interviews with the HRIs. We've completed 9 out of 12 interviews with the school districts, 2 scheduled for next week. And we've completed 5 of 12 interviews with the clinics, and 4 are also scheduled for next week. And this is actually a pretty, just one more thing about that. We're developing the process map very carefully, and then we also send the process map back to the HRIs to have them look at it. They're continuing to make refinements, and so it's really a very detailed process that we're using to try to create these maps. And they've been really, really helpful in terms of us understanding, differences across the HRIs and across school districts, and also really helpful in terms of informing survey questions that we've included in our surveys. Okay, so next slide. Also, we have really just gotten underway in the past couple of weeks distributing our TChat school survey. And just as a reminder, this is going out to school staff members across the HRIs, and we're looking at implementation fidelity, level of implementation. One of the things that we were able to produce from the process mapping interviews was a really detailed list of steps that someone would go through to implement TChat, and we had a lot of feedback before we implemented the survey in terms of what those steps are, and so we'll be able to get a good sense of what different steps different school staff are using across the HRIs. And then also looking at determinants of implementation, organizational characteristics, barriers to implementation, and just how we heard from the internal evaluation team about sort of the perceived impact of TChat. We've also asked the school staff members sort of what they think the sort of perceived impact has been as well. And again, we just started doing this in the last couple of weeks. So next slide. So we spent a lot of time and effort putting together our survey distribution list. There isn't sort of a nice list already available that includes all of the school principals, nurses, counselors, and teachers associated with TChat. So we initially identified a sample of about 91 school districts across the HRIs, representing diverse perspectives, including urban, rural, free and reduced lunch. And we spent a lot of time reaching out to those school districts, obtaining school contact lists from HRIs to really get a list of people that we could actually send the survey to. So we are in our first stage of survey distribution, and we have collected a really I think strong sample of 149 surveys so far. And we've done this in collaboration with our RICE colleagues. We did a really interesting survey distribution where we invited participants to a Zoom session, and then they completed the survey online. And so our goal is 250, and so we are now following up with people that hadn't completed the survey to reach our goal of 250. So next slide, please. Laura, I think you were going to take it over from here.
Sure. So, so moving to the CPAN clinic survey, very much in parallel with the process that we just looked at for the TCHAT, but and also to inform this survey development, we've been reviewing the literature of other programs in other states so that we're also surveying measures and looking at factors that seem to be important and influence important characteristics of other programs so that we're sure to be able to do a comparison with other programs in other states. But in line with the understanding factors influencing implementation, we're guided by it's called CFIR, the construct. It's a consolidated construct of factors influencing implementation. So with that as our framework, we've developed survey questions, including implementation practices, organizational characteristics, and then at the personal level, the knowledge, attitude, skills in managing the patients and programs, and then barriers and perceived outcomes. And we're just finalizing that and the same kind of process and constructing our framework to send out the survey. We'll do that in a couple weeks, July. So we're almost ready for that. And then, so the strengths of this is we're really, as we do this, developing several code books based on the different sources of data. So working at going to those cost meetings has been really helpful in terms of being able to understand the trait system more and utilizing that and leveraging that system to get as much as we can in terms of measures that we've outlined in our logic models from the trait, and then adding in our surveys. So that's being developed as we also develop our sampling framework in terms of developing the procedures for implementing the survey. And so we're, again, trying to make sure we get a representative sample across the different county areas covered, and including 500 clinic staff for different perspectives of the program. In the CPW, we've had 12 in-depth interviews completed, and our Rice colleague, Dr. Kianta Amora, was leading this effort, and it's we're going to be looking at the data now and understanding the perspective of the providers and their satisfaction and the influence of the program on their own training experience. And so that's underway with 3 interviews completed, 5 more scheduled. And I think, yeah, I think that's really well underway. This is just a snapshot of how we're looking at all these. You can see the different sources of information. Now, this is a pretty simplistic view of our kind of like a dashboard for our databases that we're using to guide the external evaluation. When we end up doing this, these sources will be collapsed as in like a pull down option, because a numerator could come from one source and a denominator maybe from another source in the most kind of complex scenario. But you can see where we've been really doing kind of an assets assessment of where can you get data as things are being tracked pretty carefully through the program by different players. And so we're getting a handle on that. Each of these, our goal is to have that code book developed so that when we give you our report, we can also give you these resources so that it can be sustained. And just going through mapping out our metrics and sources together. But this is our team. Could never do it without a team. And Dr. Larson, I'll just say, is our cost analysis lead, and at the same time that we're doing all this, we're monitoring costs and getting the existing data that we can to monitor cost and continuing to work on that. But we welcome any questions or comments, insights.
I do have a question. Can I just go ahead and ask it, Dr. Lakey?
Yes, go ahead.
Dr. Savas, I noticed that you have all of the divisions within TCMHCC except for research. Should we be thinking about how to fit research in here as well? And that's a question to Dr. Lakey as much as to Dr. Savas. I don't know.
Yeah, let me think about that. Let me not give an answer right now, but let me think through that. And
Thanks. I just wanted to
Okay.
raise it as a possibility.
okay, yeah, we'll discuss and see if that's an opportunity and how that fits in with everything else. Okay.
Actually, just David, just on that theme, when we present on the data governance committee, we assumed we're only looking at the 4 clinical projects. We
Yeah.
assumed research would handle their own data and we'd have no role in that. Just that's our philosophy there, just so people are clear.
Yep.
Are you trying to pass us off? Dr.
But
Blitzka?
we just figured 4 projects was kind of enough. We thought we'd let you and Dr. Trivedi handle the research data.
I just wanted to share a comment from some of the internal folks at the Institute. On the CPAN survey, we just wanted to make sure that we were balancing getting information and not overburdening the physicians. That was something, we had talked a lot about when we were creating the program, and just making sure that we're providing a service and this isn't research based. That was just something to make sure that we're balancing that.
When we've had in the cost meetings, we've been talking about that. And that was one reason we were mapping this all out. Another reason is to say, what can we not collect on our survey, and doing that next step to make sure we're not overburdening the providers, for sure. If we can get the metric from what the internal evaluation group has done and collected satisfaction, like we don't need to read that.
And we also have talked about sharing our survey back with the internal evaluation team to make sure that it is, because we have those surveys, and we definitely want to make sure that we're not asking the same questions.
Okay.
Thank you.
Thanks, Shannon. Any other questions or comments? Hearing none, thank you, Dr. Savas and Dr. Peskin. I really appreciate the work that you're doing. It's very helpful, so thanks. Quick, again, just logistical thing here. Want to, for the record, to reflect that Dr. Vo has joined us and Mike Maples has joined us. Is there any other executive committee members that have joined us? Dr. Borges, I've gotten a note that you've joined us too.
Correct.
All right. Okay. Any other members? All right. Very good. Well, why don't we go to item C then, the research initiative, the trauma hubs. We're going to have a separate discussion in a little bit related to the budget, but this discussion is on the progress. We're going to focus on the trauma hub today. And we're trying to alternate back and forth between the trauma hub and the depression hub. But Dr. Tominga, anything you want to say before we kick off this discussion?
No, I think that Dr. Nemeroff is going to carry the discussion today about the trauma network, right?
Very good.
Right. So I could share my screen, or you could share my slides, whatever you prefer.
Lachelle, you want to share the slides? Or, okay, Lachelle's going to pull them up.
Okay. Great. Thank you, Lachelle. I know that we're really busy, so I'm speaking on behalf of Karen Wagner and Jeff Newport and the rest of the team, because I'm going to tantalize you with some really exciting data from our initial findings, but I'm not going to take up a lot of your time. So the good news is we have 543 subjects that have consented to be in the study. And this shows you the monthly accrual. And we're calculating based on the current recruitment in June that we should have about 88 subjects recruited this month. And you could see we've really had a meteoric increase in recruitment. The next slide shows you, I'm going to leave this on for a minute, shows you the recruitment by nodes. Now, some of the nodes were stymied by delays in IRB. There were other obstacles. I want to give a couple of shout outs here. One is to UT Southwestern, which is leading the recruitment, as you can see. I'm very proud of our own site here in Austin, as you could see, and then Galveston. Those are the top 3 sites. There are a couple of other sites that have just come aboard and are really remarkable. So Texas Tech El Paso, as you can see, and University of North Texas, which started somewhat slowly, has certainly picked up. And then there are other sites that we're working very hard with, as you know, in order to try to increase enrollment at those sites. You also can see at the top right-hand corner that we've had 543 baseline visits, and we've already had almost 400 one-month visits and 53 6-month visits. And if you go to the next slide, you can see that our retention rate is phenomenal at 1 month. So 94.1% of the subjects that we saw at baseline have returned for their 1-month visit, which is a great retention rate relative to other trials and studies that we've been involved in. Next slide. Really excited to share with you the breakdown of our subjects, both on ethnicity on the left and race on the right. And so you can see that by breakdown of ethnicity, our Hispanic population is 43% of the sample. The US Census Bureau estimate for Texas, Hispanic population is 32.1%. So we're exceeding the Census Bureau estimate of ethnicity breakdown. And I'm very excited to share with you the race data of our subjects. So you can see that our multiracial component of 14% exceeds the US Census Bureau estimate, which is 2.4%. We are also exceeding the Native American population in our cohort of 2% compared to 0.5% in the census estimate. The Black population is exactly on point at 12%, which equals the census estimate. We're a little less on the Asian population. So very excited about the fact that we wanted to have a heterogeneous population in the trauma network, and looks like we're accomplishing that. Next slide. In terms of demographics, this is not surprising on the left relative to national data. We're recruiting more female subjects than male subjects. And then on the right, we're getting a nice distribution of the age of our subjects, with about 1/5 of them in the 8 to 11 group, about 2.5% in the 18 to 20 age group, and then the majority in the 12 to 17 age group. Next slide. Now, at the time the subjects are being interviewed in the immediate aftermath of trauma, we have been quite surprised by the already existent psychiatric diagnosis of the subjects. And you can see here that about 28% already fulfill criteria for post-traumatic stress disorder. Almost the same number fulfill criteria for attention deficit disorder, 20% with generalized anxiety disorder, and about 18% with major depression. So this traumatized population already is fulfilling criteria for a psychiatric disorder. Next slide. Now, this is the frequency of traumatic events in the 543 subjects that we have studied. And they total together a number that's astounding, that they have suffered 2,110 traumatic events in their lifetime collectively. That averages to almost 4 traumatic events per child that we see. And you can see here the distribution of those traumatic events. So this isn't just the index episode, this is their lifetime traumatic episodes. And you can see some of this is a function of our recruitment sites, because we're seeing a bunch of children in emergency rooms suffering with either medical or trauma, physical trauma related events. But you can see what the traumatic events are. Surgery, hospitalizations, seeing a family member or friend injured. But then you see the other big hitters: family violence, sexual abuse, physical violence, etc. Next slide. If you then ask the question, or is there a commonality, a co-occurrence of traumatic events in particular children, you can do a cluster analysis and you start seeing patterns emerge. What you're seeing in the olive color is intrafamilial or family dysfunction, and the thickness of the lines between the two types of trauma is a measure of the statistical significance or the commonality between them. So you see there is a commonality of witnessing violence, being attacked, a family member going to prison, being kidnapped, leaving the family. That's the olive colors. You can see the amazing relationship between bullying and cyberbullying in green, meaning many children suffer from both of those traumatic events. And then you see the sort of stuff off on the side, like being attacked by an animal, which isn't related very much to any of the other events. Next, now this is based on the child's version. This is the parents' version of how they perceive their children's history. And it's very clear that the parents document much fewer traumatic events than the children do. But again, you see these same clusters in green: being threatened, witnessing violence, witnessing violence in the media. You can see in red the sort of bullying, cyberbullying, being attacked, being a victim of sexual abuse, being kidnapped. And then you see sort of outliers like being hospitalized. Next slide. So this is the most exciting thing I'm going to tell you. And I'm going to take a minute to describe it because it's so exciting. And even though it's preliminary, it's 543 subjects. So what you're looking at here are characteristics of the children at the top of the slide: the child's age, whether they're female, Black, multiracial, Hispanic, gay, bi, trans, whether the parent's alcoholic, and the parent characteristics on the right. And all of the red numbers are highly significant findings. These are fundamentally odds ratios. And what I want to point out is a few important findings. First, the older the child is, the more likely they're going to be a victim of all of the things in the first column that are in red, like sexual abuse, media violence, family member going to prison, etc. If you look at the next column, which is sex, so what you see is that females are incredibly more vulnerable to sexual abuse. You see that number 7.59. That's a huge effect. Also more vulnerable to bullying, cyberbullying, and other forms of trauma. You'll also notice in the next column that Black individuals are less likely to be victims of sexual abuse. It's sort of an interesting finding that jumps out at us. You'll also notice that multiracial children in the next column are more vulnerable to community violence. In the next column, you can see that gay and bi children are more vulnerable to physical abuse, separation from the family, threatened violence, and sexual abuse. And then you can see that trans individuals, this is self-identified, are highly more likely to be bullied. And then we can go on and look at if your parent is alcoholic, not surprisingly, you're more vulnerable to physical abuse, mugging and theft, kidnapping, and so on and so forth. This really provides us with novel data about children that are victims of trauma. And obviously, we're going to be writing up these findings as more and more data become available. So at each of the executive committee meetings, I'm going to try to just highlight a new research finding. But this is really novel and important information about the demographic predictors that are associated with exposure to particular trauma. So that's my last slide. Be glad to take any questions.
Very good. Any
Yeah,
questions?
If I can.
Dr. Trivedi.
Sorry, thank you. Charlie, that was fantastic. Quick question. I was very intrigued in your data showing bullying and its relationship to sexual abuse, because that was really interesting, because we have a lot of data on everything, but not so much on bullying and its relationship to physical and sexual abuse. So that was interesting.
No, absolutely. We're very excited about that finding, among others.
Yeah. By the way, we'll talk. I think we are seeing similar things in the depression network, so that's exciting.
Thank you.
So Charlie, let me ask you one more question about the last slide. Those are data from the initial baseline interview, I imagine. And I guess you're going to then, in the subsequent contacts with the people, you'll start some treatment regimen. And then you'll be able to kind of compare what happens to these particular things within the especially vulnerable areas. Is that what your plan is?
Well, remember that the trauma network does not have a treatment component to it. We do have this pilot project that's been funded by the Hogg Foundation, in which 2 of our sites will be comparing cognitive behavior therapy, trauma-focused CBT with cognitive processing therapy. Our hope is that we'll be able to get additional funding to expand that treatment trial to additional nodes. So we're referring the patients for treatment. And of course, as we follow them, we'll see how treatment impacts on these findings.
Cool.
Well, thank you, Dr. Nemiroff. Appreciate the work that you and the team are doing. Why don't we transition now to Dr. Mark Chassé. We're going to have a presentation on the University of North Texas Health Science Center, the work that they're doing to implement the various initiatives. Again, we're trying to make sure we incorporate in each of these meetings a kind of a deeper dive by institution, so you can hear how other entities are trying to solve the same challenges that you're faced with. And so, Dr. Chassé, you guys are doing great work. Let me let you share that with us. Thanks.
Oh, all right. Thank you. And thank you, Lachelle, for running the slides for us. So Dr. Podewolz is in some enchanted and beautiful area of the country without Wi-Fi. And so he's left that up to me to try to pull you through our journey. Next slide. And he adds a lot of flair to these, but you'll only have to see this little cube thing maybe twice. So, all right. And we call this a path to new child and adolescent care. Next slide, please. So similar to all of our other HRIs, this is a little bit of a timeline from, Senate Bill 11 and us first meeting in August and going through different committees, and really tells you how much quick work that we did. And the budget's already coming up in January of 2020 and the work that we did through all of that. Next slide. So just to give you all a little bit of a background, John Peter Smith, Department of Psychiatry, which Alan is the chair of, has various credentialed faculty for both TCOM and the newer TCU and UNT Health Science Center Medical School. There is a robust inpatient, both adult and adolescent, as well as the liaison service a day in regards to the psychiatry emergency center. As you can see, there are about 20,000 visits per year. This is one of our primary teaching hospitals in Fort Worth, and obviously with our institution. So we had a problem without any immediate answer. The JPS Psychiatric Emergency Center was seeing over 2,000 individuals over the age of 18 each year. And many of those students were referred from, or under, the age of 18 each year. And many of those students were referred from schools and primary care. Next slide, please. So when we were all starting to doing this, Ms. Tanisha Kennard and Dr. Alan Podowitz began some weekly meetings before I was starting in on the consortium. And they worked with different folks. They visited Children's Hospital in Dallas, and worked a lot with Danielle, who's I think here today. I see her in the log, to help design what we could do for TCHAT and CPAM here in North Texas. Later, we developed and created budgets and submitted those just like most of our other colleagues did in December of 2020 and 2021. Next slide, please. So there's an opportunity for us here in Fort Worth and Tarrant County. It was an ability for us to collaborate across the freeway with our folks at JPS. And not only that, but the Claim Physician Group, which is the physician and provider group that helps take care of those patients in ambulatory clinics and also on site at JPS and their hospital system. And so Alan and I started navigating systems and making sure that all the folks were in the room so that we could most optimize what we could get and bring to our community for Senate Bill 11. Next slide, please. So we had a bunch of collaborative meetings, and because it might not be your traditional health science center and direct departments, because we had affiliated departments. We needed to make sure that all the budget offices from the two facilities, administrative offices, ITs were working together. Office of Sponsored Projects is another one that we ended up having to work with, since these were essentially kind of grant monies from our area. So we look back now, we think about how quickly all this happened. It's amazing to see two organizations working together and simultaneously going through different things from Board of Regents, their Board of trustees for their health system and the county. Seemed like a lifetime ago, but it moved pretty quickly. So we continued the collaborative approach with all of our members, and then we had reality, right? COVID-19 hit us. That changed a lot of the thinking of where we were at. It began our impact in March 2020. I know that just here personally, I was working on our testing site very close to JPS for our county and our city while this was all going on. Medical students were being sent home and doing online. Luckily, some of those students were just really needing an outlet besides going to the hospital, and they came to our testing site that we started up for about 90 days here. Faculty went home. I know here with oversight of our clinic plan here, we totally switched over to telehealth on March 19th. And over at JPS, some of the outpatient clinics were closed their door to learners just because of social distancing, in addition to unknowns. And of course, our school districts were closed as well, and most learning was going to be done online at the end of that school year. So just when we thought, what an amazing start, the world closed its doors. Next, please. So even though the place is closed, we did not stop. Obviously, we still needed to get things done. We started moving to hire and train personnel, both at JPS through a claim and also through UNT Health Science Center. And we established a contact whenever they answered the phone or called back in regards to some of the things that we needed to do. COVID slowed some of the implementation, but did not deter us. And about 90% of where we wanted to be in regards to onboarding was concluded by the end of our fiscal year, August 2020. So in looking at the RCPAN and building the team, this was the first to be hired. We considered PCPs that needed our referral ability first, and we worked on that as a team to organize our contacts in our 9 counties. And we quickly began that list in those counties. And You can see below, as of probably a couple of weeks ago, this has probably gone up, and we'll talk a little bit about that further, but we have more than 440 participants in our CPAN primary care program, and you can see a little bit of the iterations of different providers from that. Thank you, Alicia. Next slide, please. So on the TChat, that seemed to be a little bit one of our most difficult areas to start. And I think just like many of y'all, the independent school districts were closed at that time. So again, Zooms and Teams became common language, and we worked a lot with the educational leaders in those areas. And a lot of the MOUs were negotiated and discussed through Zoom and Teams. And it seems like everybody's on board, in agreement. There were just always the little sticky points that we had to do based on people's familiarity with these types of programs. So coordinating our first TChat MOU was a challenge, but we got that done. Next slide, please. So it took months of education and to try to become a priority to some of the school districts, as you know, because of so much that was going on. But we got those completed, and we're proud to say that finally in 2020, at the end of the year in 2020, our Fort Worth ISD was our first school district. And we got to begin services from them in February. And just a summary of how big Fort Worth ISD is that there's over 60,000 students there, which includes 83 elementary schools, 24 middle schools, 18 high schools, and then some other campuses. Next slide. So this is probably a little bit of older slide, but still something that's very helpful to give you a little bit of idea where we're at since February of 2020 with TChat and the number of encounters that are being provided. Okay, next slide. So on the table, we have some MOUs that are pending through some of the schools, Gordon ISD, Boyd ISD, which are some of the rural areas that we're quickly trying to roll out to, and Cross Timber School. And we have some pretty deep talks at this point with Arlington and Keller ISDs as well. Next slide. So one of the things that we have noted is that the therapist caseloads have been filling faster than we expected. And the case management is often interferes with the therapist's time to conduct some of the psychotherapy that's going on. And so we'll probably have to make some adjustments in order within some of the programs moving into the next budget cycles with some of the FTEs, because these are being filled so quickly. And we're getting some feedback on how to do that. This was just a slide on some of the building satisfaction through our TChat program, with one being pretty good, with one being on the strongly agree part. So we're staying in the one, so we're pretty happy with that, though the numbers are gradually increasing. Okay, next slide. So the next team we started to build was with CPWE. And so COVID, as Alan likes to say over here, hit Tarrant County, but it also hit us with our relationship with MHMR, because they moved to total virtual care, and they've been virtual care for a very long time. So there weren't the opportunities that we would have hoped to have with the learners with that facility at that point, but we were pretty smart enough to pivot off of that, and we developed some child and adolescent outpatient services at JPS, and used that to have established this type of relationship and rotation in July of 2021. And because of that, our residency education was expanded. Next slide, please. So moving forward, obviously we've got, like to kind of step back and tell you how many people we were able to serve. So 730 child and adolescents, and 103 newer child and adolescents to our system. And the future plans for CPWE include these rotations as our local MHMR opens up. And we'll also have Tarrant County Jail as one of those locations, general adult services, addiction services, IDD clinics that are in the area, just to name a few. All right, so the research team, as you know, we were the last ones to come aboard, but you guys did a great job of prodding us into to wanting to do this. And ultimately, I'm glad that we were able to find a lead and Cindy Clausen to be able to do this. One, we've just really got to commend all the team members from behind the scenes, especially our Office of Sponsored Projects at both facilities, and management, both at Acclaim, JPS, and the leadership at UNT to really put this together in a short amount of time period. So we've engaged, trained, we've just IRB'd ourselves to death, it seems like, but because of the different organizations, but we've been able to hire our team, and I think the leaders in the two networks would agree that we've been able to find our groove. And I like to say that we did have less on the budget, and I can say we've done more with less. So hopefully moving forward, we can get a little bit more funding and continue with that. All right, we wanted to thank Dr. Trivedi specifically for encouraging us in the participation in his study. You can see here a couple of days ago that our team had moved out in front for the consented enrollment process. So we're pretty proud of that. Next slide. And Dr. Nemiroff, thanks for mentioning us a little bit earlier. We know we had some difficult and confusing IRB review process stuff that we were working through, but I think the numbers you have were even better. And so we're happy to have started off really quick and fast, and hope to catch up with everyone else pretty soon there. Next slide. So our next big moves here, we're working on developing the Child and Adolescent Psychiatry Fellowship, and that we began planning a couple of months ago, and we're working on that. We plan to submit to the accrediting bodies in a couple of months here in August. Okay, next slide. All right. So I don't know if anybody, that concludes my presentation. If anybody has any questions, I'm happy to take those.
Thanks, Mark. A lot of great work. So thanks for all the progress you guys have made.
That's
great.
great.
We have a little bit of time for Q&A. All right, Mark, I'm not seeing anyone raise their hand right now, but again, I appreciate the work that you guys are doing, and yeah, moving a lot of these things forward. Charlie, did I see your hand? Were you raising your hand?
No, I'm just giving a shout out. Congratulations, Mark.
Thank you.
And we're so glad you're part of this.
Thank you.
Dr. Chair, may I have a quick point of personal privilege?
Absolutely.
All right, so I just wanted to let everybody know that this is going to be my last meeting on the executive committee. After 25 years of consecutive state service, I've decided to embark on some new challenges, and I'm looking forward to those. Dr. David Farmer, who is our Director of Interprofessional Education and Practice, is going to be moving into that spot, and I know he's listening in here somewhere and probably quickly working on some of his city training as he's going to be moving into some of these spots. David's very excited about doing this, and you'll be in good hands. Just want to say it's been wonderful. I think we've got a lot to celebrate with all these affiliated programs and the way we're working together. These programs have been wonderful and successful this biennium. I think there's a line of sight that's coming in the next 10 weeks in regards to the end of the biennium. And I just want to give everybody kudos for that. I mean, we survived despite COVID and snowvid and who knows what. I personally hope that I've been a huge champion for this. And I hope I've helped build a foundation here at UNT Health Science Center, which Dr. Podewilz and Dr. Farmer can move along. So I think the legislature showed our worth and what we've been able to do. And I'm excited about this being a regular biennial program moving forward. So it was great to work with old friends, and it was great to make new friends. I want to specifically thank John Scott for his support of this project and for keeping me out of trouble as much as possible. I was honored to be a part of this, and this family and sports medicine doctor feels like an honorary psychiatrist at this point after 2 years. And I wish you guys all and ladies all the best in the future. Thank you, Dr. Chair.
We'll miss you, Mark.
Yeah.
Good. Best wishes.
Thank you.
Good luck, Mark.
Thank you.
Thanks, Mark.
And Dr. Leif, if I may, just have a point of personal privilege as well. It's been a wonder to work with the UNT team, which are our neighbors to the west. And we certainly continue to have great collaboration with the teams in working, talking about CPAN and TCHAT. And so looking forward to continued success as we continue to collaborate. We do have a lot of crossover districts, roads, streets, counties, but we have worked very united and collaboratively to make sure that the kids in North Texas get the care that they need and what we can do to support our providers. And so you will certainly be missed, Mark. Congratulations on your new endeavors, but we certainly look forward to carrying the banner in your honor as we continue our relationship with UNT.
Thank you for your support.
Very good. Thanks, Mark. I'm going to adjust the schedule just a little bit. Instead of going into number 7, I'm going to go into number 9 and let's go to the presentation and discussion of, well, Nettie, the COSH update. And I'll tell you why. Dr. Williams has a graduation ceremony for her fellows that starts this afternoon a little bit early, and that's related to the consortium. A lot of those folks have been able to be part of this, and we want to make sure that she can attend. So Dr. Williams, why don't we go to you now, and then we'll come back and we'll have time for the budget discussions, which are important.
Certainly, I very much appreciate it. And Mark, I'm excited for your new endeavors and sad to see you leave. It's been fun working with the UNT team. Your team is really fantastic. And that's where I grew up, is where I went to medical school. So special place in my heart for UNT. So we'll go ahead and sort of talk through sort of the pieces for COSH. So Edith is racing ahead of me. I told you to wear sunscreen. Remember, it's getting really hot outside, so make sure you got your hats on, you're well hydrated, and you're putting your sunscreen on. But we're going to talk just updates that include WellNeti, CPAN, TCHAT, and then we'll round it out with data governance with Dr. Spliska and Bo leading that conversation. Next slide. So we have been continuing our process of, at the COSH level, trying to help engage the sort of stakeholders related to CPAN. So that includes the Texas Pediatric Society, but as well the Texas Academy of Family Physicians. We were, shout out to San Antonio. We had been trying for several months to get involved with this particular event, and we just were not getting any traction. And then finally, I emailed one more time, like about 10 days before the event, and somebody responded to me finally and said, oh yeah, you guys can come. So the San Antonio's team at the very last minute said, yes, we'll get down there. Because it was at the Hilton on the Riverwalk, I think. And so their team had the most traffic. There was about 300 family physicians across the state of Texas who came to the in-person event. And she said that they had a sort of a wait almost the entire time out, every time that the attendees were out doing the milling about part. And so they had a lot of good interactions with the family physicians. We've created this big state map that shows our state with all of our counties on it that they were able to use as well. And so again, as we can start to do more things in person, that's what we're really working to do. So we're excited for that. So just wanted to say a special thank you to the San Antonio team for going and doing that and doing a wonderful job last minute for us. We are continuing to work with both the Family Physicians Group and TPS. We're going to continue our contracts with them. With both of those teams, go to their meetings. Unfortunately, the TPS meeting has been decided to be a virtual event in October, so we're a bit disappointed with that. We'll probably still be a vendor, but it's not clear to me how much traffic we'll get in the virtual space as we would have gotten if we'd been able to have a booth that people could walk past and interact with us on. Next slide. So as we've been talking about it, it usually is the last part of our agenda, but this time we put it up at the front purposely because we have now been able to sort of launch the WellNeti dashboard. So as I'm talking, Edith is going to switch over to the actual dashboard itself. So remember, this is a dashboard that's for helping locate resources across the state of Texas. The WellNeti team coordinates with other entities that do have resources on them. So there is some back chatter with other teams across Texas for providing services. But what we're trying to do, in addition to what WellNetting is already doing, is have our team really fundamentally help add and put in more resources. So Edith is going to kind of walk through how the platform works. I'm going to stop talking now, Edith, and I'll say things here and there, but she's going to show you some of the features of this platform. This is a platform that we can use for both CPAN and TCHAT. It's not meant to just be for one or the other.
Right. WellNetting has added different tabs in here for just to narrow down the searches for the teams. They can select more than one at a time, and just add choices, and then just add their address, the address area they're looking for, or zip code. We'll just quickly add, and then we'll narrow down a list of resources. If teams cannot find a resource in this list that populates, WellNetting also has a crowdsourcing feature that they can just quickly post a question on resource that they're looking for and receive feedback from the region on recommendations. This is definitely useful for teams. They're covering for each other across the state. They can get resources for those specific areas that they're covering for.
So you see up at the top where Edith has her cursor on the different ways to search the database. This information was based on things that the team said to us, what are the kinds of help they're looking for. So this is in part how the platform was constructed to do its data search. So again, if there is not a resource that's found within the data in the resource network already, that's a pretty standard feature across all different types of resource networks, is they'll have a list of providers that you can search through. So this is pretty standard, and we have some different ways to kind of search for resources that hopefully will end up giving teams a little bit better specificity based on the sort of type of resource they're looking for. But if you get to that point, which is not uncommon in Texas, where you put in, I'm looking for a particular resource, let's say you're looking for TFCBT, as Dr. Nemiroff was talking about, in a particular area, and you put that up and nobody comes up, then you can go to this crowdsource. So who is in the crowd are the providers that are on the network. So the people that are in this actual WellNetting network are the crowd. So these are mental health professionals. So when this question is posted, the people in the network will get the question in their email, and they typically have usually within a day, and sometimes even faster than that, you will get some replies from mental health professionals saying, hey, I do know of a person or a location or a team that works, and maybe they don't know exactly what you're looking for, but they're in that area. You might want to give this team a call, or you might want to give this individual a call. So that's how it's a little bit more unique than some of the other types of resource networks, in that it has this ability to also look within the team and sort of ask mental health experts as well. So that we just wanted to show you. It's at its beginning stages. So like everything with beginning stages, there are kinks that we're working out. So we're getting feedback from teams, and we're making that information available to the WellNetting's team. And again, the way that this resource will become better and better is the more that teams put in the resources that they have found locally, that they rely on, the more that they add to the network, the better the resource platform will be. CPAN. So for CPAN updates in particular, we are getting ready to launch a statewide educational product called ECHO. For those of you who are not familiar with the term, ECHO is a type of training that started over a decade now in New Mexico, with the understanding that there was a need for specialty care, but often PCPs and family docs couldn't get access to specialty care. So they started doing these case presentations model of training. And so we're going to have our first statewide ECHO team happen in the mid of August, and we're going to go through the sort of the fall. So what we're going to do is there's going to be a series of 7 lectures. All the participants will get CME, for participating in the activity. Within the hour that the physicians are, primary care physicians are with us, they will have a 15-minute sort of high yield topic of discussion. And then they will have a 45-minute consultation. And so it's really geared towards the type of issues and challenges PCPs say that they are most interested in learning more about. And so it's really a sort of an extended, for lack of a better word, CPAN consultation. And so what we're going to be doing is we're in the sort of early phase right now where a team has been picked to sort of be the lead on a particular topic. They're sort of helping the slides get themselves pulled together. And then all the teams will review all the slides. So we have agreement across the state that this is the information we want to share in a consistent manner about this topic to PCPs in the state of Texas. And so the goal is for each of the teams to have their own Project Echo running simultaneously at the same time. And the biggest reason for why we're doing this is also about getting those relationship builds to start happening. So it's not really going to be that effective if I had an expert in something come and talk to a group of PCPs that they're never going to talk to again. We really want for the local HRI teams to start establishing relationships with PCPs in their region. So that's why we want them to be the ones giving the presentations, not other people outside of their region. All the CME is going to be free for the participants. So we're going to do standard sort of AMA credit category 1 CME, but we also are exploring whether or not to do MOC part 4, which is a type of maintenance certification credit that a lot of providers really struggle to get. And so they might be more inclined to sign up for this Project Echo if we could also possibly provide them with that MOC credit for. So we're working on seeing if that's going to be possible or not. But we're using the summer months to kind of work on the slide decks, get things arranged and organized so that by August, we're ready to go live. So that's sort of a big project for sure. And I'm pleased with that sort of progress. And again, we're hoping that if this goes well enough, this might be something that we do consistently, that we have sort of Echo team running kind of consistently. As you see, the goal is not to have that many PCPs in the presentation because it's meant to be conversational. So if you have too many participants, then it starts to not become conversational, and then you sort of lose some of the value of the goals of the activity. So we're not looking to sort of have 300 participants be in it. That's not the goal of an Echo project. So that's why we'll need to hopefully, if it goes well, repeat, rinse and repeat, and attract more and more PCPs into it.
Laurel, can I ask a quick question or make
Yes.
a point? We were assigned the preschool section, and we got one, I guess, from the University of Alabama. I had some real concerns that it was not clinically focused enough, and maybe also for some, too simplistic for the PCPs that do deal with a lot of difficult issues. So we're pretty much completely redoing that one. But I had similar concerns about a lot of the pre-existing Echo slides. And I agree that we should all have a single slide set, but that may be a bit of a task because I think I invite, what I would say is, maybe I'm off base. I'd invite everybody to look at those slides carefully because I'm concerned a lot of them need some substantial revision if we want to kind of be as useful to the PCPs as possible. Now, if everybody else looks at them and says, oh no, Pliska, you're full of it. These are great. I will stand corrected. I'll stand down. But, I've got some concerns in that area. And I think the last thing we could do is if we present something to PCPs and they say, oh, we've heard that, but that's not clinically useful, we could have the opposite effect. We could turn people off. So that just in the Echo set, I thought there was a huge variability in the quality. And I just invite everybody to look at it. Maybe before we launch, make sure we all have feedback on that.
Yeah, so Dr. Pliska is bringing up an excellent point. I went to nationwide to kind of ask other teams across the country how they've done things. And, we're trying as best we can. I was thinking about the external evaluation team here. We don't want to reinvent wheels. If there's wheels out there that have been put together and they've been tested and people felt that they gave good outcomes, we want to try to, allow them to help inform us what we're doing. But at the end of the day, this is going to be Texas's Project Echo. So we are going to have, like I said, the first level of vetting is one team was assigned one topic, and there was a slide deck that came to that topic. They're going to make changes to those slide decks based on what is the most available up-to-date evidence and information on the topic. And then every team is going to have the opportunity to see the corrections and then provide input about whether or not those corrections work or they have a question about it. So at the end of the day, for these 7 presentations, every single HRI team will have an opportunity to review them and make sure that they feel comfortable with the information that's being presented, and that we all as a team say, yes, this is the information we want to provide to our PCPs in the state of Texas. So it's not going to be a one-off that just one team looks at it. We are going to have everybody's eyes on it. So it's certainly a valid point, Dr. Pliska, for sure. Okay. So yes, we're working on that, and we'll certainly see how it goes. It's 14 weeks because we do the topic every other week. So that way, hopefully we can get PCPs involved. We talked with a couple different teams about how long to make the series, and most people really landed on anywhere from 6 to 7. Doing more than that tended to see the sort of participation really drop. So this is our first foray into it, and we hope it goes well. Next slide. Maybe. Edith. Yeah. So in keeping with that idea of trying to have best practices that we as a state CPAN team see ourselves as providing, we are going to be doing some mandatory trainings. We've been doing CPAN now for a year. We've gotten a lot of lessons learned. We've gotten feedback from evaluation teams, from HRI teams themselves, from other stakeholders, primary care physicians, physician groups. So one of the things that we've heard and listening loud and clear is that we want to have standardization so that there is not a sense that you go and talk to one HR team and you have a very different CPAN experience than if you talk to another HR team. So we're doing this training in part to help us improve our own standardization. But another piece of feedback that we had gotten was that we do have a PCP consultant, Dr. Tran, and it was her recommendation along with some of the HRI teams as well as TPS itself, that they really felt like it might be better if we had sort of a panel of consultants for the end users versus just sort of having only one person kind of speak on behalf of this large diverse group in Texas. So what we're working with is with the Texas Family Physicians Group as well as TPS, that we're getting 1 to 3 sort of physicians within those 12 regions who want to participate with us and be these consultants. And they're going to actually co-train with us on these 3 days. And so the goal of that is for them to also, as end users, provide us valuable feedback about how they would like us to provide the CPAN service to them. And so we're really actually hoping that as a result of this training, we're going to gather a lot of really good information about ways that we can help improve our engagement with providers and also make sure that we really are, doing a service that they see as valuable and that they would want to both use themselves, but then tell their friends about and get additional providers to start using. So we're going to have the training across 3 days. And while teams are being trained, other CPAN teams will be taking those regions calls while that day's person's training is going on. So again, there's really a dual purpose to this training. Yes, A is partly to help us all be on the same page, but it's really to engage our stakeholders even more so that we can make improvements as need and then have an additional group of providers who can go out there and be, helping us spread the word about CPAN and its hopefully good use that providers can have with it. So she's going to transition now to just the numbers that we have for the state. Just give her a second. She's super good at this, and so it helps me be less nervous. Because I can't, when I try to do 2 things at once, it doesn't often go as well as I would like. So thanks, Edith. So as you can see here, At the top, we have, as of May, I've enrolled 5,574 providers across the state of Texas, within 974 enrolled clinics, and we've had over 2,500 completed consults on 22 unique patients served. And we have continued to hit our benchmark of being in the above 90% with our callback time, and the median time that they can speak to a child psychiatrist in the state of Texas is 8.7 minutes. I argue you wouldn't get that anywhere else in any other CPANs across the country. In my opinion, we're doing excellent here. As you can see here, once we move to allowing for a verbal agreement for participation in CPAN, we have seen the number of light blue, which means that they have started the process but not completed it. That number has steadily been declining. So again, we are having increasingly additional engagement with completing the CPAN agreement that we had developed. As you can see here, the staff enrollment is also very high. And again, the largest percentage of types of clinics that we are serving are pediatric clinics, followed by family medicine, and then integrated care clinics. Down to the next bit. As I had anticipated this, and I had been sort of telling teams in advance to sort of anticipate this. As we move into the summer months, I did kind of expect that we might see a little bit of a dip in the number of calls. People are going on vacation, school is starting to come out. So I think that there's opportunity in this sort of May, June, July period in particular, that we might sort of see a little bit of static within the volume of calls. I do expect that August will start to really see a huge bump up again as kids go back to school. And we're actually developing some engagement processes around the back to school push to both highlight CPAN and TCHAT at the same time simultaneously with the HRIs. But as you can see here, the majority of times when somebody calls the CPAN is still the physician at that 66.6%. And then down to this one last piece here. Again, the vast majority of the time, a provider is calling about a specific patient. They are often asking for help with finding a resource. So speaking of WellNeti, and speaking of our sort of share, collaborating and helping each other out, having a resource list that's up to date and can help us search efficiently is going to be increasingly important. About 45% of the time, they are asking medication-related questions. We've seen the about an emergency kind of hold steady at 5%. So emergency can include either suicidal or homicidal concerns for a patient. So that's not dropped, but it also hasn't increased. And the vast majority of the time, they are looking for us to help them find either a local therapist, followed by looking for a child psychiatrist. A smaller percentage of the time, again, those kids that are in an emergency situation, it does look like that we are around 3% of the time, 3.5, recommending a higher level of care. So one of the things that we're not showing here with this particular dashboard is that each HRR now has what's called their mega data. So each CPAN call itself has about 130 data points attached to it. And so this mega data is now available to HRIs so they can start looking at their own data to start helping them with around how they're going to engage, reach out to providers, answer questions that they might need to answer about quality control, and practice improvements, performance improvements. So now that they have access to that particular very detailed data, we're hoping that will also help further their both enrollment and engagement of providers across the state. And then the very bottom, there's not really been any huge shifts in the demographics as far as the ages of kids or genders of young people that were being seen. Remember, we didn't start making the race and ethnicity field mandatory until March. So it's probably going to take a few more months before we'll feel comfortable that this is actually sort of accurate when it comes to race and ethnicity. Just moving back to slides. TCHAT. So school's out for summer. I think it's an Alice Cooper song, if I remember correctly, a little bit before my time, but still a classic. School is out, but that doesn't mean that TCHAT is out. TChat is still open for business, still accepting referrals. All the HRIs are still accepting referrals, but we're also mindful of the fact that we might potentially get less referrals because school is out. Yes, there is summer school going on, but for schools, a lot of times summer school is a really high pressure, gotta really help kids with credit recovery. And so there's not always as much ability to maybe let them go spend an hour or two having an appointment with us. So a lot of the teams have sort of worked on additional activities that they could be doing over the summer. I'm not going to show the attachments, but I really think that several teams are doing phenomenal work, and I wanted all the HRIs to see some of the sort of outcomes of different teams' work. So that's why I have so many attachments, is it's showing you some of the different educational materials related to the additional activities that a lot of the HR TChat teams are doing. Say that 5 times fast. So basically what again, the HRIs reached out to different school districts and said, what would you need over the summer? What could we provide over the summer? So there was an opportunity to provide some additional programming around groups, educational groups, and also to help both the kids, help parents, and even help some school personnel. And then also because we are expecting that there will be a lot of anxiety returning to school next year. Obviously, all kids in Texas were in a very different state because of COVID. And there is an unfortunate expectation that we're going to see a fair amount of anxiety with the return to normal operations. And so we're partnering with most of the HRIs are partnering with their local ISDs to kind of think about how the TChat team can really help the reentry for kids and families as they return to school in a sort of more normal way. For TRAIT, we are working through sort of the complete sort of process for getting the data from referral to actual end of care summary. The expectation is that we will go live July 1st with all aspects of the data collection process that TRAIT will be providing for us. 11 of the 12 teams are currently putting in their referrals for TRAIT. One team is still having a challenge. Welcome to, speaking of, I was thinking about our Chesse and like all the different players. One team is still struggling because just because they have like 3 institutions that they're kind of working in, they needed to get an additional BAA, and that is just taking a little bit more time, but they anticipate that it'll hopefully get sorted by that July timeframe. Right now, all the HRI teams are working to get their training so they understand how to utilize the system, so that July 1st, we can move forward with it. And again, on some level, it's useful that we're starting using it in the summer when referrals are down. So if there's any issues or challenges or things we need to improve about the platform, we'll have, about 6 weeks, 5 to 6 weeks before school starts back up and we are really running for business again. As you can see here, because we didn't meet last month, we had I think our peak in referrals was in April. As you can see here, May, we're starting to see that decline for most schools across Texas. May was the end of school, although HISD stayed for 2 more weeks into June. That was painful, by the way. So we've had a total of 1,200 referrals, and like I said, 11 of the 12 HRIs are using TRAIT to put their referrals in. As you can see here, we have across the state of Texas have 193 different different school districts that have put referrals in, which again speaks to the wide variety, and a number of schools, 674. As you can see here, there had been a question earlier about maybe thought we would see mostly adolescents. So I think you can put that to bed. So this has been fairly consistent that we actually do have a pretty nice rule of 3 split between kinder, early childhood, latency, and then adolescence. So about a third across the ages and school grades. This information is a little bit new. One of the things that TRAIT has done for us is we can actually see the reason for referral. And so you can see here that between April and May, the sort of top 4 reasons for referral included depression and anxiety. But I also want to call your attention to that, unfortunately, young people having suicidal thoughts is actually also relatively high. And then beyond that is trouble paying attention. So these are sort of, for lack of a better word, bread and butter things that our teams are really well equipped to help with. So, on some level, it's reassuring that we're seeing that these are the reasons for referral. But on the other hand, it's also showing the level of distress that young people are in and the reasons for why TChat was a program they wanted to use. We wanted to just go down the entire list there here. So speaking of sort of the depression network and now the trauma network, about 12% of young people are being referred because of a trauma. And then specific self-harm behaviors, changes in sleep, harm to others. We do have a large category of people listing others, so they're choosing not to select a particular topic. We've actually been working with the Data Governance Council on that, and we are going to be making some changes to help improve people picking an actual reason and not picking other. Because once they pick other, either they put something in there, and what we're discovering when they put things in the other is they're actually one of the categories they could have just selected, but for whatever reason, they maybe didn't read it all the way through, they're putting in others. So we're making some changes based on the Data Governance Committee's recommendations. So we expect to see that other percentage drop precipitously when we move into the new academic year. Again, this is not much different than what we have sort of been talking about. There's a slight preponderance of young ladies versus young men. And then again, we've had another conversation as well around the sort of issues for race and ethnicity. One of the things that we're talking about is a limitation, and we're talking through how to do this, is that the school counselor is the one who puts the referral in, not the family. So we're thinking this is actually an area where we can help train the school team. Our thoughts are more to the school is just maybe not asking the family so that they put decline versus that the family actually really decline. So we think we're going to use this as an opportunity when we do our training to kind of work with the school around potentially putting that down. But we're also going to be training teams to ask one more time when they actually call the family and speak to them to see if there is it really a decline or just they didn't know that the information was being requested. So I was trying to move through quickly enough because Dr. Pliska-Zimbo had some important updates related to the data governance, which I know we're making the title longer, Dr. Pliska. So I'll leave it to you to talk about the longer title and the purpose for it. Maybe. Hopefully, Dr. Pliska.
I am here.
Yay.
Yes, so if we can put up the data governance, management and governance committee charter, or there we go. So this relates to issues that we've discussed before about really how we're going to manage the data in the 4 clinical projects. And there had been 2 separate processes. One was a data work group that kind of was dealing with nitty gritty, and then a data governance committee that was dealing with higher level issues. And we decided to merge those into a data management and governance committee, or DMGC. If we can scoot up so everybody can see number 1 membership, basically this committee will consist of a representative from each health related institution. We want to limit it no more than 12 people who are also members of the executive committee, because we don't want an inadvertent quorum rather. Obviously the director of COSH, members of the internal and external team, and there'll be various representatives of the central administration, mainly Luann and Lachelle and Negla. Then also all of the vendors that we have right now, that's principally Trait, that are involved in the data collection process. But the members of the HRIs and the internal, external will be the voting members. Of course, we'll maintain a appendix that will list the current membership at any given time. You just look at charge. So really, this will be the committee that will oversee the COSH. We will hire a data manager administrator that will help execute all the decisions of the committee. We'll establish the data definitions. We'll be the ones determining the methods of data collection and storage. This would involve overseeing the modification of the software that's involved in that. Now, right now, that involves trade. Very good example is there's a problem with people not defining the referral question precisely. So we discussed that and we gave direction to trade about how to deal with that. And there's likely to be any number of issues like that that are come up over the course of the project. We'll interface with Molly and David to be sure the internal evaluation team has all the necessary resources. Ultimately, we will be commissioning data analyses, determining the data dissemination. When we get to the issue that we want to publish or publicly present, we will kind of oversee that and give final approval. And then we would vet any non-HRI requests from external sources for data other than from the state government itself or from the legislature. So a university says, hey, we hear you're doing this great project. Could you send us de-identified data? Because we would like to look at X, Y, and Z. The data management committee would look at all of that, say, yes, we think this is a valuable thing to do. We will send you the data. Actually, I think the rest of this is details. If we can go ahead and go forward. This really defines, operationalizes what I just said. So if we keep going forward, I want to get to, stop here for a moment. So we often are getting situations and HRI says, hey, it would be really great if trait did this, or could you add this, or that's not working. And heretofore, Laurel has had to vet that request and kind of struggle with whether to do it or not. So now we will have a formal process where at the HRI, at the operations committee for each project that meet monthly, we would kick those ideas around. If the operations people say, a majority of them say, I think that's a great idea, then a change request form would be filled out. It would be submitted to the data manager who would vet the request, and then that would come to the data management and governance committee. And then we would say, that's a great idea, that's a terrible idea, we're not going to do it, or it would be a good idea, but we suggest the following changes. And then we would be the ones that would officially approve that and say to Trey, whoever our data manager, data gatherer is, go ahead and make that change. And the goal there is to maintain the integrity of the data. Because if we spend 6 months gathering data with a certain question, say, and then we want to change that question, well, we have to think very carefully. We don't want to screw up the data so that it basically becomes meaningless because we're asking a different question. Our audience, our participants are interpreting the question in a very different way. And of course, we'll need to keep a log of all of these sorts of things. So can we move forward? The request for data, each HRI has already designated a data representative, and they basically will submit a request. Hey, I want to see my data. And we will say, fine, we'll send them that data and they can look at it and look at it internally. Naturally, external requests will come in. We'll look at those with a little bit more scrutiny, make sure that all HIPAA, FERPA regulations are adhered to, and then any data we send to them naturally will have to be completely de-identified. Next. There are many situations where we will commission a data analysis. We may also designate who's going to do that. So most likely there would be a lead group at each HRI. Would you please do this data analyses for us? And naturally, the internal and external evaluation teams can do that on their own, independent of DMGC. Perhaps this is probably want to make sure we're not trying to be exclusionary in any way, but we really think it's important that the consortium speak with one voice on the publication and dissemination. So while HRIs can look at their internal data on a project, say do internal QI or to see where they're going, we would ask that no one present or publish a data analysis without the review and consent of the DMGC. So naturally people can describe their projects like we're doing already. You know, here's our CPAN, here's our TChat, this is what we're doing. But when it comes down to really crunching the money, the numbers and coming to conclusions, then I think the DMGC would want to weigh in at that point. And similarly, as people present PowerPoints, manuscripts, we would vet those and approve those. And there's a process for doing that. Naturally, there could be appeal to the executive committee if an individual HRI felt the DMGC was being too restrictive in any way. And then at some point, we're going to want to publish articles as a group. And so we're going to need to determine, we'll have a corporate authorship, which would be the Texas Child Mental Health Care Consortium. And then there'd be a footnote in the that would refer the reader to all of the particular authors who are individually getting credit for that particular situation, which yeah, and okay, so I'll stop there. Open for questions, and at some point we obviously would ask for a vote if people want to approve this document to go forward.
Thanks, Steve. Really good work putting all this together. Dr. Thompson, I see your hand.
Yes, Steve, outstanding. It's really well organized, but I do really have some significant concerns about the issue about that. I would need to go to the DMGC if I want to talk about data that was generated from El Paso. I do think that each site needs to have some ability to publish their own information without having to get permission from a central committee.
Okay. Well, the counterpoint would be, suppose an HRI wanted to say, we've looked at our data and we conclude at our site, CPAN was completely ineffective. Or we looked at our data and, TChat's not a valuable way to do that. I think that would be a big problem. Now, no one would do anything that extreme, but any one site that publishes their data, that's going to reflect back on the group as a whole. And you could get into if each different HRI is publishing different experiences, I think there's the danger of confusing the public and particularly confusing legislators about what the ultimate, what the results from the consortium have been. Now, again, we're not restricting people talking about their experience, but I think I would have a problem if somebody said, well, we have outcome data at our site. Even if they said in the article, there are 11 other sites who might have different data, that I think that would lead to difficulty.
Can I add to that, Steve, just to help you a little bit? So in the research, we're pretty used to that, because when you create multi-site study and it's funded as a multi-site study, although every site collects its own outcome data, there is a general publication committee that oversees that and approves publication of the data per sites for exactly the same reasons. So people will not start reporting a little bit different data from different sites, and then whoever reads it needs to reconcile. And that makes really no sense. The data should be published in aggregate. And that's actually mandated by MAH. So
okay.
this
just like Steve said, the counterpoint of that is the experience in El Paso is not the experience in North Texas. And In addition, if the experience in El Paso says that TChat doesn't work, and then you're going to tell me that I can't tell other people that it doesn't work, that you're restricting my ability to say those things, you guys get into some issues there.
Well, I think remember, all you would need to do is you would present your thing to the data management governance committee. And if we felt, and we're going to be liberal about this, it's just if your presentation is very reasonable, sound science, I think, yes, we would do that. If you come back and you say, well, we did outcome data, and 10% of the people returned their surveys, and of those people didn't benefit. So that's our conclusion. We would say, no, respectfully, we don't agree with your analysis. If you say at a certain point in the project, we've got outcome data on 200 people, then they'd probably be more favorably disposed. But there's other ways. If we have site differences, then there are statistical ways to look at that in terms of a site, by, I'm struggling with the right term, site by something, outcome interaction or whatever. And then we do that analysis. The similar could be reverse. We don't want people to start claiming, incredible, miraculous results, that then other sites don't find. And it may be based on some statistical fluke rather than on some actual difference between sites.
I mean, I hear you. I think there's the risk that people will not be conscientious, but I do think there's a bit excessive restrictions in the rules that you've generated.
Well, the committee meets.
It might be that we should set this aside for a broader discussion some other day, because there's a number of data sets that are going to be generated in TCMHCC overall, and it's a general question for all. And I don't think that we're headed. I think that we need a special time to discuss this, I would suggest.
And if I could just make a quick statement, I definitely understand both sides. I do think there's, it really gets into an issue of academic freedom if an investigator wants, or let's say a researcher wants to write about data from their site. I think the people reviewing that should be the journal editors and not a subcommittee. Now, if someone's speaking on the behalf of data for the overall project, I fully agree with the committee that Steve has set up here. But it's just my thought.
But Mike, if you're in an NIH multi-center study or a industry clinical trial with multiple sites, individual PIs are not allowed to publish their own data. Yeah,
I do agree with that. And Dr. Liberson, this gets back to another issue, which when we get to the research, I'll chime in on it. But I do think we can publish really important research based on the services here, and it does make sense to have a committee to speak, at the statewide level. But again, I think academic freedom needs to be considered for if someone wants to write something about their particular.
So let me go to Dr.
It's not a research study or an NIMH study.
Let me go to Dr. Nemiroff and then Dr. Liberson, and then I want to weigh in real quick, and then we can kind of think through the process of this, Steve. With the group.
So reasonable people do reasonable things. And many of us have been involved in these kinds of very large multi-center studies, whether it's NIH or other funding. And the fact is, no one would ever prevent Dr. Thompson from publishing data from his own site. But it is important to have a unified group. The research network has already talked about this, about we already have a committee to review spin-off projects. And that committee will also serve as a publication committee for the research networks. And so We're not worried about this, Peter. No, nobody is going to stand in the way of you wanting to pull data from your site, and it's important. But there has to be an orderly process that's timely, and reasonable people will be reasonable. So I'm not worried. I know the people on this call are going to be fine.
Then Dr. Liverzon?
Yeah, I absolutely agree with Charlie. That's it's always there is a balance between the freedom on one hand, but also in the need of some kind of organizational coherence on another. That's why there is such a thing as a funder, and funder usually defines, and usually when there is a grant like that, there's a publication committee. And that's exactly the service what it does. It just looks at that and balances the value of getting, but the question is not really, is it valuable enough? But usually things don't get published if there is a contradictory data, if there is some issues that scientifically don't match and so on. Obviously, everything can be abused if you're putting people in unreasonable places. So I agree with Charlie that the main idea of this type of review is mostly coordination and not silencing anybody or getting any type of oversight of the data. It's more thinking, are we speaking in the same language, and is a funder is agreeable to this process? And NIH is pretty clear. Other places, maybe there are different ways, and a state might decide a little bit differently. But I think we can agree on eventually on this process.
David.
I'm going to agree with Carol that I would like to have a separate, more thorough discussion, because this is not an NIH project. We're not NIMH.
A separate time would be good.
Yeah.
Yeah, I think what we do need to have folks have a chance to look through this and read through it and think through details. I would, though, also note that this isn't an NIH project. The fundamental purpose of the legislature putting in $118.5 million is the improvement of child mental health services. There were guidelines the legislature gave us related to how we could use this type of clinical data, not in an aggregate, to drive improvements. And I think there has to be some governance related to it, because we can't have every independent researcher at institutions asking Kosh for their separate pieces of data, et cetera. And so I don't get the sense that we're ready to vote on this. I think it's a really good document, Steve, and let's let folks have a chance to dig into it a little bit and think through, and have some additional conversations offline before the next meeting. But plan to come to the next meeting with, as much as we can be in consensus to be ready to kind of move forward with a document like this. Yeah. Dr. Trivedi, did you want to say something?
Lord, and I obviously have to know, and I totally agree with Israel and Charlie, but I think one of the issues we as a team should be thinking about is, I don't think that generally the danger is that there's too many publications. Our problem is going to be that there's not enough of it being done. So creating any infrastructure we create needs to be less onerous so that people are encouraged to publish.
Yes. We need to encourage, but we also need to make sure we're following the direction of the legislature on how we are stewards of the tremendous resource that they handed to us, and need to make sure that data requests doesn't become a major challenge for the Kosh as they're trying to do that and provide all the other essential clinical services to make sure these $118.5 million worth of projects move forward in the direction the legislature envisioned. Steve?
The Data Management Governance Committee meets weekly. So this is not gonna be like you would send something, like you sent it to an IRB and it's gonna take 3 months to review. We would get back with you immediately if we thought there was an issue. We're wanting to have this structure so we could deal with, I want to do this analysis, but wait a minute, we've got another analysis in place, the internal team has come up with something that looks different. What's the reason? This committee is the way that would be, would be an orderly process by which all of that would be resolved.
Can I add something to this too, please, Dr. Linke?
Alex.
There's a lot of work going on with the data governance and data work group that Dr. Pliska just mentioned. We do meet every week, and there's a lot of requests that comes through, not necessarily on publication of data, but there's a lot of decision that has to be made. And Dr. Pliska has put together an incredible draft that I think all of us agreed on the bulk of everything except for this one piece. Rather than, I think, waiting on voting for the whole document, can we just tease out this one piece and get the rest of the documents voted on and approved? So that way we can continue to work on the other issues that and requests that comes up on a weekly basis without holding it back. And then we can vote on this very separate issue, taking it out of the current document, and vote on this separate issue at a later date. Is that amenable to everybody?
I don't think so. I think we need a discussion on the whole thing. I mean, you can't just, how would you know what's carved out and what's not carved out? Many people have raised many issues now. We need a separate and distinct.
Well, that's why it was sent to you earlier, so you can review it. But I guess if you want to review the whole thing again, but we're trying to move along with a lot of work that we have to do.
So is everybody.
Yeah.
So
Alex, where I kind of measuring where people are, I think at the next meeting they'll be ready to vote it out, but there is a desire for some folks to have some additional discussion on that. Now, Steve, Dr. Pliska, in those discussions, got to make sure we don't have a quorum, right? Got to make sure that we're very careful with the number of people that attend.
Yeah.
But we can have to make sure that we have the person that Dr. Thompson needs to be in that conversation, whether it's himself or somebody else at part of that conversation. But they're going to need to limit that as a one person per institution conversation to make sure that we're following the Open Meetings Act rules.
Dr. Lakey, one of the things we can do is send out a list to the executive committee is as to the names of the individuals who are on that committee so that you will know. And I would suggest then that if you have comments that you would like to make, that you could do that with the committee member.
Great.
Steve, does that sound like a plan to you?
That's fine with me. Yeah. That's fine. We can continue with the mechanical day-to-day work under our current mandate from the executive committee. And then I guess we need to have clear guidance on how we're going to deal with this issue. And so it sounds like there's not quite consent. There's some degree of consensus. So hopefully we can get that by next month so that we move forward.
I think we're mostly there. And again, was just challenge the group that this is a little bit different than other types of research projects that you have. That this isn't, the legislature wants to be careful with this information and make sure that there's the right governance in place to make sure that we're the good stewards of the funds and the data that they're entrusting us with. Okay.
I mean, I'd be curious to hear how the research group wants to handle this very issue. Like, Charlie presented today looking at all the data that he's got. If one site came out and did an analysis that was the opposite of what he just showed us, how would we deal with that? Mm-hmm. So that's kind of the core issue.
Yeah. But we're not the research group. I mean, so just to.
No, but in some ways, though, we're dealing with sensitive clinical data.
A quick suggestion: when this data group meets, would you be open to inviting Dr. Thompson or others to discuss with you?
You can.
There's a representative from.
There should be a representative from HRI. The only question is we can't.
Which one? Okay.
So you can either you can designate yourself as long as we don't have a quorum on the committee, or you can designate your person.
Someone else. Okay.
Yeah.
That's great. I would think you guys can work this out.
Nobody's going to be left out when they'll always have an advocate there if they say they want to present certain data.
I think if everyone goes
in
in
reasonable, regardless of the case,
working together, you'll get it done.
Mm-hmm.
Dr. Trivedi, you wanted to say something and then we'll need to move on to the next.
No,
topic.
sorry, I didn't lower my hand.
Okay. All right.
Yes. So
So-
let me just,
Yeah.
let me just sort of say one thing, this was based on feedback because teams did want to have representation within the data governance committee structure. So we have had in our state CPAN and TCHAP meetings, we've heard the feedback from each of the HRIs, and this is in part, we have asked each HRI to give us one person per HRI who has understandings around data and sort of the use of data to be a representative on the committee. And so far, most HRIs have given us one person's name and they've started to attend the meeting. But we're waiting to hear from the final group. We were trying, Dr. Pliska wanted to show that list with everybody today, but we didn't have all HRIs had not given us a name yet. So we definitely will have it at the next meeting. You will see the representative from each of your HRIs on the list.
So again, very, very good work. I think you're mostly there and need to take the feedback that we've heard today. David Lean raised his hand and said, I need to go to him.
Just real quickly, just listening to this come together, this is obviously a really important conversation that this committee is going to be having. I just want to give a slight lawyer's admonishment. There's a representative from each HRI in that meeting, and then maybe one or two others, but then each of you takes the product of that discussion back to your counterparts at your institution. You're essentially having a full discussion that would need to be held in an open meeting. So I encourage you to think of this discussion that you're going to have like any other committee discussion, which is that your work is to prepare the item for discussion with the full executive committee in an open meeting, and kind of sort of keep it that way and keep that in mind.
Yeah.
Thanks, Dave.
Yeah, David, if there's any language we need to tweak to make sure we follow all those rules, you feel free to put some edits on there or whatever as we go through this process.
Will do. Absolutely.
All right.
Okay. All right. Let's transition then. Steve, did you want to do the CPWE update?
Yes.
Okay.
Just a moment here. Let's see, it's going to be very brief. The collecting the data for the LMHAs in terms of the activity metrics, number of unique patients and number of visits, that seems to be going smoothly now. Where the spreadsheet arrives with me every month, I immediately forward it to the CPWE person designated at each HRI. Molly has a spreadsheet that she sends to each HRI so that they can document the number of patients seen at the non-LMHA sites. Our next major task is, as you recall, we changed our metric from patient outcome to a metric focused on resident outcome, resident satisfaction with the rotation, and resident attitude toward community mental health. And we need to finalize that process so those assessments with the residents can go forward. Note that the external team is interviewing the residents in CPWE as a separate process. We'll also be tracking that data internally. So it's likely that residents will get two sets of assessments over time, although it will not necessarily be the same resident that we sample. Other than that, I don't have any other major updates. To my knowledge, the program is going smoothly at all sites.
Okay. Any questions for Steve? All right. Hearing none, what I think I would like to do is give everyone a 15-minute break so that you can grab something to eat or take a convenience break. And so why don't we stop the meeting and come back together at 12:30, at which time we're going to jump into the budget discussion. So I'll see everyone at 12:30. Thank you. We will be starting in a little less than 2 minutes. So please finish up anything you're doing and see you right at, actually it's 1 minute now, right at 12:30. Thanks. Very good. It is 12:30, so why don't we go ahead and resume? We're going to jump into the budget. Let me give a kind of a high overview here related to the budget, and then we'll jump in a little bit deeper. But as we noted, we feel very fortunate that the legislature put in the total of 118.5 into the budget, which meets our current needs. We are having discussions right now with institutions. They have identified a variety of opportunities to grow, whether they're other schools or other local mental health authorities that they would like to partner with it in the future. And so we're trying to now pull that, with no growth, we're at budget. With growth, that is more than we can, all the opportunities would put us a little bit higher than where we are currently funded. And so we're going to be working to make sure that we pull it into that number. I got a message from Carol. Carol needs to potentially jump to another meeting in a little bit. I'm counting heads, and I'm still good with my quorum. But if you have to leave, please let me know, because I need to make sure we keep at our at least 18 members here to make sure that I don't have any quorum issues. But I'm going to bring Dr. Minga and have her talk through the research component of this. Again, that has to be part of the 118.5. The legislature put in the budget at $10 million total for research. The challenge that we're going to have, and just talking frank with everyone here, is that the last biennium, we started research a little bit later than the other entities, the other components of the projects of the course consortium. And so now, instead of funding for 16 months, we have to fund for 24 months. There's been some startups or start off costs that we need to be mindful about to make sure that we figure out what was needed for startup versus continuing impact and implementation. But there's a little bit of a challenge to make sure that we are fully within that budget. And so let me hand off, Carol, to you. And again, appreciate the work of you and Dr. Nimroff and Dr. Trivedi of kind of thinking through how do we adjust going into this next biennium. So Carol? Carol, are you here?
I don't think Carol's back from the break yet, David.
Okay. She sent me an email. Let's see here. So why don't we jump, Michelle, if Carol isn't here, let's jump to the other parts of the budget, and then we can go back to the research component.
Would you like me to show the consolidated data that we pulled together? Okay.
And Lachelle's been working while we've been talking, and I appreciate everybody sending her information. We got the last little bit of information this morning. She's putting it together. Again, kind of bottom line, we have obviously enough money with the legislature to keep us at the current level of care. The question will be managing those additional requests.
All right. Are you seeing the big spreadsheet right now?
Yes.
Okay, great. All right. Well, thank you everybody for getting me your budget information. This is a lot of numbers, I realize, so I'm just going to quickly go through what I'm showing you. We've got FY 22 and FY 23 here, and that includes the original budget and then what everybody has given me as their new estimate. Where people have identified some growth opportunities, that's in the column here, and with comments about what they're hoping to do with those funds over in column Q. If I look at what the original biennium budget was, and then compare that with the new total estimate, you can look at these two here. And we're actually under in some cases, but with the growth requests, we are higher. So for TChat, it looks like we've got some quite a lot of growth requests compared to the other initiatives, around 5 million per year, 5.7 in FY 23. A lot of that is to expand TChat services, which I believe is in alignment with what the legislature would like to see, but we're going to have to work on how we fund this given where we're at. And I'll go over the high level summary of where we're at in just a bit. For CPAN, slightly less requests for growth and smaller in nature. We're at 1.1 million, 1.3 overall. If we look at what everybody's requesting compared to what was originally approved, again, we're under if we eliminate the growth piece of that, but slightly over on CPAN with the growth piece. On CPWE, there were 3 institutions that are requesting additional funds to expand the program, including Texas Tech El Paso, Houston, and Health San Antonio. Overall, we are over on our base request for the biennium, and then we also have some growth funds for those 3 institutions I pointed out. So looking at a 4 million shortfall compared to what the original budget was there. And then on CAP, overall, very, very close, slightly higher, but 8.6 million versus the 8.2 that was originally set aside. There were some assumptions made about some of the new programs and the costs that would be needed to stand those up, and some of those were underestimated, and so that's why we have that variance there. But if I look at the totals.
And can you increase the font just a little bit?
Yep.
Thanks.
If I look at the totals, there were some assumptions. We're still working with the COSH to finalize their budget. We've assumed external evaluation, administration, research remains the same. So the original approved budget for the biennium was the 118 million. If there were no growth requests, we would be at 115. So there would be some funds available to use for those growth requests, but it's more around the 2 million mark versus the 12 million that it's looking like we would need if we wanted to approve everyone's growth requests. The other thing that we've got to be cognizant of is that 10% change allowed between initiatives. Right now, with the CPWE ask, we're increasing that to 29%. And I think, as Dr. Lakey alluded to earlier, it's not that we can't do that, but we will need to inform the LBB and get their consent before we could do those kind of changes. But the bigger problem is right now we're about 12 million beyond what we have funded here, the 118 million. And so we will need to work with each of you to better understand what impact the additional funds that you are requesting will have on the state of Texas, and making sure that we're allocating funds to be get the biggest bang for our buck effectively.
So let me just add a couple of things here. And again, Lachelle, thanks for providing the summary. We encouraged you to give us some additional ideas. There are several of you that I said, put that on the table. And I, again, appreciate you putting all those things on the table. We'll be able to get into budget. The challenge will be that in some areas, we're not going to be able to grow as aggressively as some institutions saw that there was opportunities, whether they've been contacted by another school district, et cetera. TCHAT continues to be a priority for the legislature, and we'll need to make sure that we try to do that to the extent that we can. We're going to need to all kind of sharpen our pencils and make sure that we can figure out if there's ways with that, if there weren't as many additional funds, can we do some of those things in a smart way? I know all of you are already thinking about some of those ideas, but I think for our team, now that we have all that information, we're going to be laying it out in big spreadsheets and trying to figure out what's doable and what's not doable as we make sure everyone's needs are met and as many additional kind of wants or opportunities that are really be strategic for the state are met within the budget. So kind of process wise, we're having those institution by institution conversations. We will be needing a lot of feedback from you as we try to figure out how do we get this into the right form here. But appreciate you, all the work that you guys are doing, and for putting some of those opportunities on the table and what they would cost. And if we don't have that information, we wouldn't be able to make some of these decisions. Alex, I see your hands up.
Yeah, thank you. I just wondering if do you have an ETA of when you will be able to provide us with feedback on some of these initiatives could grow or not?
Yeah. So here's part of our challenge group is that some of you need to go to your systems board of regents to get approval. And those institutions need to do that by August so that they have the monies approved so that come September 1st that they can not have any lapse in funding for their physicians and the staff. So therefore, we're going to need to have, now that we have this information, again, we're going to have in the next several weeks these conversations with your teams. But come into the meeting in July ready to approve a budget for the consortium and move forward. And so our team will be meeting with you, Alex, your team and others, and getting feedback over the next several weeks so that the July meeting, we can give final approval and your institutions can go to your board of regents. Does that make sense, Alex?
Yes, thank you.
Mm-hmm. Any other questions on that?
Dr. Lakey, I'm sorry, I may have missed this, but assuming that we're not going to spend 130 million and we're going to try to get it down to within appropriation, what does the process entail to decide how to go from 130 to?
So everyone's needs and what they asked for before, we're going to be able to meet those. And then again, that gets us at the 115. And then there's a little bit of additional funds. And so our team will be working with each of the institutions, figuring out what is doable and trying to prioritize that, talking with folks individually, and then come to this group with a proposal at our next meeting and where we think that those opportunities are and how we get into that budget. And then this group would need to approve it. Okay. Shannon, does that make sense?
Thank you.
Yeah, just to clarify in case there's confusion, the reason it appears as though we are over is only because we have asked HRIs to provide us with information about growth opportunities. Mm-hmm. Otherwise, we are operating within the budget. So I just wanted to be clear that we're not over in any way for what the legislature has appropriated to us.
Yep.
Wanted to make that clear.
Yep, everything that you guys asked us for last fall, the amount of money that you asked and said that you needed to continue operations, we put in the budget, and it's been funded. Where some of this extra wiggle room comes in place is that some institutions figured out that they could address some of these issues a little bit differently. And so there were some cost savings and other adjustments. Then that gives us a little bit of opportunity. And again, we're going to try to make sure that we, as possible, take advantage of those opportunities. But your current staff, your current levels of funding in each of these are there. And all we're talking about is how we can be strategic in being kind of under budget and making sure that we use that to address new opportunities.
I think
Does that make
Dr.
sense,
Wakefield
people?
had a question.
Yeah, just Dr. Wakefield.
Yes, hi. My question is that on the meeting on the agenda, as far as I can tell for July, we were going to have a Chairs of Psychiatry meeting. And so are we changing that?
Yeah, we're going to have to adjust that from the feedback from the systems of having to get things approved. And so we're going to use that.
We are one of those systems, so I would appreciate having the meeting in July, but I just wanted to make sure.
So we're going to use that same protected time and to clarify kind of that comment. The Chairs of Psychiatry. We have another group that has just the Chairs of Psychiatry and state agencies meeting together. We are under quorum because we don't have two people. We have a smaller group, but that group is talking about some adult mental health issues and some of the things that we couldn't discuss before the Children's Mental Health Care Consortium was established. And this group, if we ever get a quorum, has to be under an Open Meetings Act. But we're going to use that time that we had previously planned for the chairs meeting to be the time for the consortium as a whole, so we can get the final approval for the budget. Okay. Any other questions? So another part of this then is the research part. And Carol, let me bring you in. Again, appreciate Carol, you and Dr. Nemiroff and Dr. Trivedi working through how do we best use that $10 million, understanding that we now have 24 months and versus the 16 months, and keep all the efforts going and make sure that we're good stewards. And so why don't you share some of your thoughts and the slides that you put together related to how we do this?
Great, thanks an awful lot. Before we start these slides, I would love to say, just a minute. Do I have to do something here? Right. Yeah, before we start, I would just like to say that the research group presented ideas for growth to Dr. Lakey and his group even before they asked. But in fact, they asked us to keep to our $10 million, and we were grateful enough to that so that we went ahead. If I could have the next slide, please. I just have two slides, one to talk about the research productivity, and sort of how we look back on what we did during the first biennium and how do we look forward to the challenges for the future. So that, you've heard from Dr. Trivedi, you've heard from Dr. Nemiroff today, and you can see that we have really developed two networks across Texas with 12 nodes per network, one in depression, one in childhood trauma. You can, every meeting, you'll hear reports from some of the data from the networks, and it gets more and more exciting the more data that we have. The node recruitment varies, as you saw today from what Charlie's presentation was, but mostly it includes all of the nodes, and we're slowly moving forward with the nodes that are only now getting started. Now this is a typo, each network, not each node, but each network now has more than 500 volunteers for each, within each one of the networks. And you can tell just from Charlie's report today that the more data that gets in a network, the more scientific use can be made for those data. What is the consensus of everybody in the research, in the two research networks, is that these volunteers that the networks are meeting up with, both in depression and in trauma, would not otherwise have come to medical attention. Here's another typo. It was too late last night. Medical attention. I'm sorry. Either that, or I think I have the wrong slide set up here. So that the children that are being seen, the 500, more than 500 being seen in trauma, more than 500 being seen in depression, would not have otherwise come to medical attention. The outcomes that we see are new, and that will certainly inform the field. And you saw some of those today. Now, there are certain challenges that we'll have going forward. One is that the funding that we have now, and our funding will stay the same. The funding that we have now will have to extend over 12 months, not just the 16 months that we had last time. We've increased nodes. You heard today from the University of North Texas. We've increased the nodes from 11 to 12. So now we have all of the 12 health-related institutions from around the state, and we're really appreciative of that. As the recruits increase in number, of follow-up will also increase proportionately. You know, these people are seen at baseline, and then they're seen again at various increments that differ in the two networks, but they're seen increasingly over time. So we'll have more and more appointments to follow. And now the work of the hubs is really changing from standing up the research nodes around the network, and it's changing to maintenance. It's changing to managing the data. What do the data mean? How do we analyze the data? And how do we manage this all going forward? So in the next slide, you can see the research budgets as we planned them. And I just want to point out that at the present time, the percent of the total $10 million is 40% of it goes to the two research hubs, and 60% of it goes to the 12 research nodes. And I've laid out here how things go. I want to say, though, that to say that $1 million goes to a research hub doesn't mean that that research hub just gets $1 million to do whatever it wants to. That $1 million that goes to the hub is put into resources that are used by the nodes. So this is really an integrated budget between a central group that plans the research supports that's needed by the nodes, and the nodes then are the main people that go out and recruit the subjects. So that that $4 million overall will be dedicated to the centralized research support services. And then with respect to the research nodes, since there are now 2 years, we would figure each research node has $125 per node per year. That's for a single network. Since so that's really a budget of $250 per single node per 2-year period. If we recognize the reality, which is that each node has really is part of 2 different networks. Each node has $500,000 per 2-year budget in order to do both to collect volunteers, both for the depression network and for the clinical trials network. And that for the research node, that's equals up to $2 million, and that is 60% of the total research budget. So this is just a very, very broad and general outline of how we'll manage things going forward.
Hey, thanks, Carol.
That Charlie presented before, because you can see the directions of both the recruitment of the volunteers and the diversity across the state, and that all of the nodes are represented. Thank you, David.
No, thank you, Carol, and again for transparency. You know, Carol and Charlie and Dr. Trivedi and I have talked a couple of times over the last over the preceding couple of weeks, trying to figure out how do we again, figure out how do you go from 16 months to 24 months with the same amount of money. And I really appreciate them being willing to take a deep dive and a sharp pencil into the hub budgets to, significantly decrease them. And so they, it's there were some contracts, there were some first-time costs to get things stood up, but they also cut into other areas to try to get to that $1 million while being able to provide everyone the same support. And so this is kind of the initial presentation of that framework of trying to have 40% hubs, 60% in the nodes at the institutions. That gives your institutions 500,000 over the biennium for both of them. Yeah, the other item that we've talked about, and just kind of I want to just be again transparent here, is that a couple things. One, University of North Texas, we pulled them along. I think it's very important that we have all of your institutions part of this, and we wanted to make sure UNT was going to be able to be part of this. And as they're demonstrating, they are one of the top performers, and they are funded less per year in the last budget than the others, because it was, they were the last one to get pulled in. And so we need to make sure that they get a equitable part of the, that an equal allocation as the other institutions. Some other institutions have had some difficulty standing up the initiatives, and again, there are real issues there related to space and contracts and IRBs, et cetera. We still want to have them part of this. Again, I think it's pretty powerful when we have all the HRIs in the state and being able to recruit from rural and every urban area, et cetera, the border, being part of this. But we also need to make sure the institutions that are getting the funds are standing it up and are on the path of recruiting individuals for these studies as we continue to provide them that allocation coming into the next year. Steve, I see Steve Pliska, Dr. Pliska, I see your hand. Let me go to you and
I guess it may be too. I don't have my research budgets right in front of me that we're currently funding, but do you anticipate most of the nodes that are participating could be able to maintain their current effort and personnel? Is that going to be one of the goals? Or are we going to be potentially looking at cutbacks in terms of, because if we lose research associates or faculty have less time to devote to the project, that's going to adversely affect recruitment.
Well, Stephen, let me speak to that. So both the nodes and the hub had a large yes of funding because of the late start that we had. So each of the nodes is very clearly going to have a set amount of money that's going to be spread out over the entire time period. At a later date, we could talk about the rate limiting step, which is the payment of the subjects. And so what we might entertain as a possibility would be that funds would be held by the central hubs and be used to support subject payment for those nodes that were recruiting large numbers of subjects. And in that case, then some of the hubs that were not recruiting at a reasonable rate might get somewhat less. And that's something we can talk about. And we've had some dialogue about this. Fundamentally, I think everybody should operate on the notion that you're going to get $125,000 per node, per network per year.
And I think, Charlie, that was pretty clear in the slides that I showed. That 250 per node per biennium is no decrease in cost, although the work will go up a little bit. So all the hubs and the nodes will all have to be a little bit more efficient.
No, just to be clear, Maduka and I have both had to dramatically cut back on the hub budget because of this having to live within a 24-month period. So the salary support for almost all of the people in our hub has had to be reduced.
But Lachelle, you have the most detail on the amount of money that went per institution last time, and you've looked at these numbers. You want to kind of share kind of where the other institutions were on funding over the last year?
Yeah, when I and it does vary depending on the node, but overall, I think you have to look at year 2 because that was the only full year. And if I were to take that number and double it, I think most people were closer to the 600,000 mark versus the 500,000 mark. So there is a reduction if you look at how it's being drawn across the full 24-month period. And where that's going to impact, I can't say, is it staff, is it from the patient incentives, but there is a definite real decrease across the full biennium if you just look at that year 2. And that's for both the hub and for the nodes.
And again, that's the challenge of going from 16 months to 24 months.
Yep.
Dr. Escamilla?
Yes, hi. I did have some comments on this. I've got a few points. If you just bear with me for a minute here. First of all, I just want to say the networks are really important, and the 2 PIs of them have done tremendous work getting those all off the ground and having all of us together as part of the network. But I am a little concerned in the in the service of transparency. It's the research budget, which is $10 million for 2 years. And I think if the state's giving us that, we really should be the best stewards of that to do important research that's going to benefit our citizens and also, prime us for external funding. My question is, there was a research committee initially to look at how we use those funds, and it seems like that's been dissolved. Although there's still a chair, possibly. Maybe I could get clarification, but it seems like Dr. Taminga is still, pretty much putting this together with 2 other investigators. I am concerned that by doing this, we're committing all of our research funding to these 2 networks, which in the original biennium, there was no peer-reviewed application process where anyone could apply. And the way the budget that's being presented is, if you look at it in its totality, there's a $2.5 million that 2 schools are each getting, and all the other schools are getting about 0.5. I think there's lots of other studies that could be proposed, and I would just encourage us to consider having a research committee with a representative from each site to look at how we are proposing to spend $10 million.
So the research committee, Michael, as you recall, came from the executive committee. It wasn't a research committee with representatives from all of the HRIs, but it was really all of the research people who, all of us on this committee here. So you're suggesting getting that research committee back, or are you talking about forming a new group?
Well, yeah, I guess, what I'm wondering is, has the consortium made the decision that the $10 million in research funding is all going to be for 2 projects? And if that's the case, then our hands are tied. But if not, there should be a research committee to decide if this is how we want to spend all our funds for 2 years, or if there's other ways to be more effective and have more impact for the state.
The idea of getting together the research committee is not a bad idea. Maybe we should do that.
We can do that. I guess a couple of quick points. And Charlie, I see your hand. I'll go there in a second. Just a couple of things. One, I did get feedback from before that some folks that weren't part of the research committee wanted to bring those things up to the full executive committee to have decisions, and wanted to make sure that those conversations were fully open, and that every institution had as equal play in that. And I guess the other thing I would say is that in our conversations before with the legislature, et cetera, the thoughts were that we would continue on these, then come back next session and say kind of what was next, but really didn't put in that we would be really changing. Because the conversations would be that we would continue this, and then at the next session decide if we needed more money or kind of move in a different angle. Dr. Nimroff, I see your hand.
Yeah, so I'd like to just point out that both of these projects, which were approved by the research committee and the entire executive committee, were based on the notion that we were recruiting respectively 2,400 and 4,000 subjects. That was required in order to begin to answer the questions that were posed. So any idea about diverting from that project would fundamentally abort the work that we've done over the last biennium. And so, it just doesn't make any sense.
I suppose the other thing to point out, Charlie, is that what's being done now is really the collection of these two networks. And the research that's going to be done with the collection still is, it's very, very broad, and there are many, many different possibilities.
Dr. Trivedi, I see your hand.
Clarification, at least from my angle, and that is the goal was not just the project, Michael, I thought. The goal was to stand up a research network across to be dealing with these two areas of work. So even the question that whatever committee is formed will need to be discussing would be, is the idea that we change the topic of the work, or and even then the research network will be really the heart of that, right? The first task was to create the research network. Because if you're really thinking about it purely as a project, then there would have been a very different selection process and a different approach. So I'm wondering how everybody is seeing that is something that needs to also be clarified. Otherwise, we will be in the business of being a lot more helter-skelter in this approach. Maybe even a worse use of the money.
Okay. Luann, I see your hand.
Yes, I wanted to clarify for everyone. I know Dr. Escamilla said that it does appear that UT Southwest and UT Dell are receiving 2.5 million. That is accurate, but the 0.5 is so that both of those institutions can participate as nodes, so that all of the institutions get an equal amount, which is 500,000. That is why it appears to be that way. It's to spread equitably the amount of revenue that goes to each one of the institutions that are participating in the nodes. I just wanted to clarify that.
And again, the goal of the hubs also is that their efforts are to support other institutions and not just themselves. Octavio, I see you, and then Israel.
Thank you, David. Just a quick comment, because I think Dr. Escamilla is bringing up a really good point, but I defer to you, David, and it might be worthwhile just to remind folks, and my memory, I'm just making sure is right, of how we came to be when we did the initial proposal to the legislature. And so the chairs of psychiatry, prior to them being moved over and also being part of the executive committee, we went through an entire process where we were preparing to present this proposal. And in that, we had a lot of in-depth discussion with the chairs. If you all, at least this is how I recall how we all discussed this, guys, of one, that can we put research into the whole proposal to stand up TCMHCC, and we felt that we could. The concept was definitely the infrastructure to have the networks for research. And if I recall, there was a whole process of where we entertained and asked for what should we then do our initial researches on. And so we went through a process where we landed on the two that we have today. And that was what was presented into the legislature that was stood up. Just going back and kind of reflecting on what I recall, how we ended up where we are with today. I think as we're moving forward, and now that the infrastructure is in place and these two research projects have taken off, how we want to add additional research makes a lot of sense to me. But just to Michael's point, are we locked in? From my perspective, as I recall, we are to a certain extent because we're still in the early phases of standing up the research infrastructure. But David, I defer to you for the minutes and clarification if we need that as executive committee.
Can I just add one thing to what you're saying, Octavio? I remember it like you're saying it, but also we had woven in the idea that we needed to do something that was very important to Texas. So we wove in the healthcare, the learning healthcare network idea that we would do some research that would form a learning healthcare alliance.
Yeah, I agree, Carol. Absolutely. And that's when we brought in all the HRIs and
yeah,
that was the concept.
Yeah.
And Dr. Liverzon, I see your hands raised.
I-
I ask folks
Yes, I'm
to
here.
say something to raise your hand, please.
Yeah, I'm trying to.
One other
Waiting
thing, I
patience.
think there is
That's-
room, if there was a research committee with representation from the different nodes, I think we could look at more effective use of money, even if the money is just going to go for these two networks. I think there's, again, this isn't the place to get into detail there, but I do think, you know, just last time I feel like the hubs are over budgeted.
Dr.
Hard to
Liverzon?
hear you, Michael.
Sites.
Let me try again. I think there's two separate questions, one for the process, another one for the content. And I think that people addressing them in parallel. But it's important to realize what we're doing. We have decided on some of the content of our research effort. And we voted, we presented it to that. There is some long-term commitment of maintaining that. I absolutely agree both with Charlie and Madhukar that these are very important initiative to continue, and we are committed in some way to support them. I don't think that Michael had anything of that kind in mind or not to support them. On the other hand, there is also the question of the process. Within, as you know, we adjust everything. We adjust the budget as it is, and we have to adjust it up or down based on what we have. And how is it get adjusted? What is the process that is involved? Is there other priority that can be written in or not, as Michael says? That can be decided or should be decided on a regular basis by the group of people and not only by the two hub directors and Carol, which Carol was supposed to be dissolved together with the rest of the committee. So in order to us not to look like an old boy network that has, and one lady, that makes the decisions on the whim of subgroup of people, I think Michael's suggestion of restructuring or reinstituting a body that represents that and ask those questions. And then Charlie and Madhukar correctly can bring up our commitment to continue the network to that point and see and discuss that. I think it's appropriate. I think we can have a place for both for Michael's suggestion of creating the right way of managing that money and stewardship of this money, and as well as that committee, it's based from us that we're all contributing to those networks. We understand the critical need in continuing those networks and supporting them and so on. I think what I'm saying is not negating neither what was Michael was saying, not what was later mentioned by Charlie Madhukar.
Dr. Wagner.
So I agree with many of the points that have been said and what Israel is talking about, two separate processes. But I would say that we have a responsibility, from my perspective, to complete these projects that we all agreed that we were entering. We owe that to all of the volunteers that started in this longitudinal study to see these projects through. And then when they're through, it's reasonable to certainly have a committee that would discuss where do we go next, what's important, because things change obviously over time. But I really do think we have a responsibility to complete these projects as we all agreed that we would. And for the people that have agreed to, all of the volunteers that have agreed to be with us in this process over the next couple of years.
And to be clear, I did talk to Dr. Nemroff, and I did talk to Dr. Trivedi, because coming into this meeting, I needed some boundaries of proposals, kind of where they were and kind of what they can do. And again, I would say that they can, just be clear, they've cut their budgets by about 25% going into this kind of 40-60 proposal. That's not a done deal. The goal was to have something that could be discussed in this meeting. And again, we'll take your input as we continue to work on it.
I don't see Michael's suggestion in any way implies that anything that the network is not doing enough job or not important or shouldn't be continued or not using the money very well. I think what Michael is simply suggesting is
correct.
appropriate management of the process, so we all feel that we're all involved, and not only we all feel that, but also this is how it's perceived by the public and the legislator. So I'm applauding the idea, and this committee might decide to keep exactly as it is the budget.
Okay.
There's a bit of a question about what the committee ought to be, though. Should the committee be one person from each HRI, or should the committee be the standing research committee from the executive committee? David?
And Carol, what I would say is the reason that I brought it to this committee as a whole, because I heard from several of you that you didn't feel included in those discussions, and that there seemed to be a group that was smaller that then had made a decision. And so that's why I'm trying to have this discussion in the full open meetings to get that input so that everyone can hear where institutions are. Now, if the direction from this group is you heard that, and we still need to have again, kind of take it off and have somebody from each of the institutions have a separate conversation and then bring back a formal recommendation to this group at the next meeting, that is fine. But again, it's going back a little bit towards that other group that's not in the open meetings, trying to put things together. Steve Pliska, I see your hand. Steve, you're muted.
Yeah. Sorry. Okay. Yeah, there I am. So I guess what this proposed committee would handle, and in a short period of time, is kind of the question. Like you said, Dave, you put forward this as a preliminary budget for the research to kind of move the current projects forward over the next biennium. It seems. So the question is this, what will make this the final? Are you going to, if there's going to be what's that process? Are you going to kind of continue discussion and then we're going to vote in July? Now, and if we need, we can either all as a group right here continue to discuss, talk some more in July and vote, or we can have a committee discuss that and then make a proposal to us. On the other hand, if this proposal, the hubs have said they're going to make this sacrifice, which I definitely appreciate, and because it does at least allow all the nodes to continue their current work and do the recruitment, then to my mind, I don't know if a committee is going to add a lot more. If there's going to be we got to put more money back with the hubs, or we got to drop some nodes because they're not performing well, those kinds of mega decisions, then probably a committee representing all of the HRIs might be of value. So I'm very ambivalent about reactivating the committee, but it depends on what it's going to do.
And again, if it's reactivated, it's going to be different than what it was before. Michael Escamilla, I see you, and then Dr.
Yeah,
Nemroff.
David, sorry, I got cut out last time. My system went down there. But I just wanted to clarify, I'm not at all saying we shouldn't continue these two networks. I think that's critical that we continue them over the biennium and that we, keep them going. I do think there's room and some guidance that could be given in terms of how the money's distributed. And I think there might be some redundancies, for instance, within the hubs, that we could come up with some recommendations that might benefit the whole network. And my last thing would be, if you do get that committee together again, I really think there should be a representative from every site, because every school has different issues in how they can contribute to these networks.
Dr. Nemiroff and then Luann.
So I just want to be clear that to comment on Dr. Pliska's statement, Maduka and I and Carol made the decision that in spite of the differential performance of different nodes, that we would not, in spite of the budget constraints, we would not cut any node out of the network. Okay. And so that would have been an easy way to try to make up for the budget shortfall. But we made the decision that that wasn't in the spirit of what the entire networks are about. So we're taking a tremendous hit on the hub budget. All of the salaries are being reduced. Everybody who's being supported by the hub is being reduced in order to be able to maintain the nodes. The idea, Michael, of having the two hubs in an economy of scale, they're completely different networks. They have a completely different databases. They have completely different metrics. And, you know, I've tried, you know, Israel is a member of our hub. You're a member of our hub. Okay. Jair is a member of some of our committees. We've tried to be as transparent as possible. I feel really strongly that we made a commitment to the state for both of these networks, and that we have to see it through. And frankly, within, you know, there isn't any money left over. So 2 years from now or 18 months from now, if the group wants to come together, in my mind, and say, we want to end these projects, and we want to have a first episode psychosis project or a perinatal network or whatever, I think that's the time to get the committee together and brainstorm about it. But what I don't want to do is have a bunch of people get together, spend a lot of time when there's no there, right? These funds really are committed to the projects that we all voted on.
Luann, let me go to you, and then Dr. Trivedi, and then I'm going to kind of pull this together into kind of a plan. Okay.
Just a few logistical things. One of the reasons why this research discussion, as Dr. Lakey mentioned earlier, is at the executive committee level, is exactly because each one of the HRIs wanted to be part of the conversation. We would not be able to have all of you on the research committee because that would result in quorum issues for us, which we cannot do. And so that's why we are having this particular conversation at the executive committee level as opposed to a other committee level. The other issue that we have is many of your institutions have been emailing us regarding the FY22 and 23 budget and are very anxious to learn what the final numbers are. Our timeframes are very short. As Dr. Lakey mentioned, we are having a July meeting specifically because we have to approve a budget before your boards of regents meet in August for their quarterly meeting. So the time frame is very short. We would not be able to finalize a research budget in time for July 30 meeting if there were issues that needed to be addressed by all of the institutions together, which is what you are asking for. So I'm just encouraging you that there are some rules that we have to comply with in addition to a tight time frame for the budget. I'm not exactly sure how to resolve the issues that you have in relation to those two things, but I did want to raise those.
Thanks, Luann. Dr. Trivedi? Dr. Trivedi, you are muted.
A couple things. One is just a plea to all of you. well-meaning people, Michael, I totally agree with you. Well-meaning people cannot come up with 33 different or 300 different research ideas. The question is, do we stay with each of the parameters that we were all working under? We could think about doing genomic research or imaging research or blood-based biomarkers. That wasn't what we were charged with. So that's the first thing. The second is, I personally, to the extent I have a say in this, I make a big plea to all of you to not cut off net nodes, because at this stage, we are just beginning. This is a statewide research networks that we have built. Nobody in the country has built this. And if you want me to write books about it, Michael, I can write books about it. We've done it, and let's not break it up because for a little bit of time, somebody was having a hard time performing. So that's my 2 cents for the plea to all of you. Because this is, think of it not so much only the project, but think of it as a serious research network that has stood up across 12 nodes. And we have just begun. For example, at UT Southwestern and Baylor, we're performing well, but the primary care part of the extension of this research network is still beginning to be built, so that at some point it'll multiply into a bigger setting. So I think that is something we should all be mindful of. This is not a small endeavor, and we started on it. And then it almost reminds me that after the first third, I just attended an Ironman competition. After the first, if we say, let's slow down, that might make it very hard to win that marathon.
All right, I'm going to go to Israel, and then Dr. Ibrahim, and then Dr. Plitzka, and then again, I'm going to try to pull this together into a plan. Okay.
So,
Israel?
Yeah, so very 2 comments. I absolutely agree, both with Charlie and what Madhukar just said. I think it's a perfect decision not to cut anybody. I think it's the right decision. Again, I don't think there is any wrong decision have been made. I also want to say that I didn't see, when I support Michael's suggestion, I didn't see that in a context of vote by the end of this meeting in July, because I think it's a more long-term thing, what Charlie was talking about for 18 months, or whenever we decided that we have some more flexibility for what's going on. We need to be practical. So my support, and maybe Michael also added to this idea, had to do with more general establishing the appropriate representation and the process, while I don't have any problem with what I've decided so far and ready to vote for it, even if there is no committee by that time, but maybe later.
Okay, very good. And again, kind of time-wise, I have to come out of the next meeting with a budget so that the Board of Regents can vote on this at your various institutions. And so that is my timeline that I'm working under. Dr. Ibrahim and then Dr. Plitzka.
I've been listening. I understand completely the need for inclusion, transparency, shared decision-making. I just feel like we just need to be very careful about 2 things. First, not to undermine the projects that are ongoing, because that actually will take us backward with the legislature, with the state, and so on. So that's one piece. The second piece is, and I know no one is saying that, and I think you're all supporting keeping the nodes that, the HRIs that have not performed similarly. I think, the HRIs are not created equal in where they were when you started. So I think allowing the network to really develop, allowing, those that did not perform the same time to develop expertise and so on would be good. But I understand where Dr. Escamilla and Liberzon are coming from. And I think if we succeed with these 2 projects, I think it opens up the door, both in terms of having a network, but also in terms of getting into new areas of research in the future. I'm not sure what the research committee will do at this point. I think the research committee will need to be revived if there are new projects and or new divisions of labor within. But I think you have an executive committee that has all the HRIs, so I'm not sure why going back to the research committee at this very moment will help with any. That's my opinion.
Very good. Thank you, Dr. Ibrahim. Dr. Plitzka?
So I guess I'm being very concrete. So this research budget's been proposed I don't see any way that it's really going to change. We're going to keep all the nodes, and I agree with that. The hubs, the hubs have made this as much of the sacrifice as they can make. So I don't know what keeps us from approving this now, other than then we just want we got to put it on the agenda for July and approve it. But I don't see the need to make any changes to this. If people disagree with that, then we need a process for how it's going to change, or we have to have extended discussion at the next meeting. Just focusing concretely on the budget, apart from a research committee monitoring. I share Luann's concern. I want to keep this moving so all our contracts can flow efficiently. So I'm ready to vote, but if others want to wait till July, that's fine.
So let me divide this into a couple of concrete votes here by the executive committee to kind of stepwise through this and determine the path. And so I think maybe a first concrete vote is to reaffirm that the research use of these dollars will be the continuation of these two research projects we've stood up, depression and trauma. And that will be the research effort, and have that as the first vote. Then I have a couple of others to kind of walk through that. Does that seem like a reasonable decision that the executive committee as a whole can reaffirm right now? And if so, can somebody make that motion?
Dr. Lakey, this is Dr. Bryant
Yes.
calling from Tyler. Does that mean that would continue to include all of the nodes? Because I know that as a node that joined 7 months ago, and we are definitely in last place in terms of engaging participants. We're working very hard to fix that problem. We've had a number of challenges, and we really are working very hard. I've been working with Dr. Newport on trying to address some of those challenges. So we would be very disheartened if we were dropped as a node. It's not for lack of effort. I'm hoping that somewhere in here there's a commitment to allow us to continue to participate.
And so Dr. Bryant, my thought process was that would be a second vote from the group and a confirmation that all entities would be included. And so trying to narrow down kind of where we are on this. And so the first, and I would ask again from the folks raising the hand, if we could get that first vote that the confirmation that the research initiative will be the continuation of the depression and trauma networks. I think if we can reaffirm that, then we can.
So David, I think that the person who articulated that the best was Karen. And I would think that maybe if Karen could again articulate the argument of going forward with the two networks that we have.
I think we just need a motion, right?
I think we just need a motion and confirm, and then additional discussion and vote.
I'll make that motion, David. Jair here.
I have a motion by Jair.
I second.
I'll second.
I have a second, and both Dr. Wakefield and Karen. And so the motion on the table is the continuation of research based on these two initiatives. Any further discussion on that?
Just to clarify, the thing we're voting on is that all 10 million will be spent on those two projects and nothing outside of it. Is that correct?
Those are the two initiatives. All 10 million will be spent on those two initiatives. Okay.
With the limitation, this is what we're talking about, the upcoming biennium.
Yeah, on the upcoming biennium.
Not in perpetuity.
Yeah, for the upcoming biennium. Yes, sir.
Yep.
Okay.
We did have a third network when we were initially discussing that, one focused on early psychosis, but we figured that we didn't have enough money really to do 3 networks well. So we would pick 2 of them. And personally, I think that the 2 of them are so strongly started, it would be difficult to, it would be a real waste. And it was just what Karen said.
So I'm gonna be very concrete here and kind of moving through this. And so Jair, I heard a friendly amendment to your motion that the motion is that for the next biennium, the totality of the $10 million will be used to support these two networks and initiatives, trauma and depression. Jair, is that a friendly amendment?
That sounds good. That sounds good.
And Dr. Wakefield and Wagner, you still second those motions?
Yes.
Any further discussion just on that? Hearing none, all in favor signify by saying aye.
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 Okay. Anybody opposed signify by saying nay. I heard zero. Are there anyone that's abstaining?
I'll abstain. One.
Okay, Dr. Escamilla abstains. So let the record show that there was one person abstaining, there were 0 nays, and the rest voted affirmatively. I think maybe the next decision point is that all 12 entities will be continued as a node for each of those initiatives.
So moved.
I move that that's the case.
I'll second.
I have a motion by Dr. Wakefield, and I think a second by Dr. Ibrahim.
Yes.
Is that correct? All right. Any further discussion?
Sure, let me just chime in here. The money that's going to the nodes is, so this study is transformative in 2 areas. One is the data is just incredible, but the other is the transformation that occurs in these institutions that are less research developed and don't have a culture of research. This is what's making us have a culture of research, and having the resources of Austin and UT Southwestern for us to learn from. I can't tell you how important it is for the department and for El Paso.
I agree. I completely agree. And Tyler, I mean, we are just getting started. We've doubled our size of our department twice just in the last year. So there's so many changes going on. We're adding a medical school. We are really in our infancy compared to the other institutions, but having the resources of Dr. Nemiroff, Dr. Trivedi, Dr. Wagner, Dr. Tingle, the whole group has really had the role of mentorship. And that is so important to us. So even though we haven't performed the way that the other institutions have performed, I hope that is not a sign that we will never perform that way, because we are kind of starting from scratch in terms of that research culture.
And Dr. Bryan, I really appreciate that. And I think all the institutions that haven't been as high performing, there were some barriers there that they are addressing. I think there's power for it, having all institutions involved in the research initiative. I do think we're going to need to make sure we have those, frequent conversations to make sure that entities that are getting the dollars are enrolling, and we're trying to break any kind of barriers and watch those numbers closely. But I do have a motion and a second to approve that all 12 institutions that are currently funded would be able to continue funding, at the current level, at a level to keep them part of this initiative. Okay.
Hey, this is Octavia. Could I just add one thing? It might be reiterating, but just reminding everyone that this was the intent and idea of Standing Up Texas as being modeled for the entire nation, to have the collaboration of all the HRIs working together in research, because they represent different parts of Texas, and we're very unique because we're so large, guys. We're 1/3 of the nation population-wise. And what happens in El Paso is so important with UTRG versus Dallas, Austin, Houston, you name it, across the Northeast, Texas, Lubbock, that concept is what sold this to the legislature. And to have that type of research capacity, not only for the 2 initiatives we've identified, but for the future of what could be done, is just truly tremendous. So I'm probably reiterating, but I just want to point out that is what brought us all together. So I'm very, I think all nodes must be included.
Okay.
It's inspiring to listen to Octavio. And also, I just have to say that for everybody in the Dallas site and for everybody in the Austin site, this was very important to have everybody included.
So I have a motion and a second. Any further discussion? Hearing none, all in favor of including all 12 institutions and having them all get funded as part of this research initiatives and functioning as nodes, signify by saying aye.
Aye.
Aye. Aye.
Aye.
Anyone that's opposed, say nay. Is there anyone that abstains? Okay, so we have a unanimous vote that all institutions will participate as part of this research initiative. I think the next part of this conversation, and see if you're ready to vote for this, would be that only 40% or 40% of the dollars would be used for the hub component of the budget, and 60% will be used to fund the nodes. Any discussion on that?
For the next biennium.
For the next biennium, absolutely.
So, you know, David, I didn't really intend to present anything more than merely a summary budget, you know, so that the numbers that I laid out today were very, very gross. And didn't include any of the detail. And it may be that people want the more detail. I'm only raising that as a possibility.
I think you're going to have to go back and provide that. But I think if we could establish that that is the framework of 40-60, with the majority of the dollars going to the nodes, 40% for the hubs, that can move us forward in constructing the budgets in a way that we can get something to your border regions on the timeline that we need. Dr. Pliska, does that make sense?
Yes, in fact, I'll make the motion. I move that we accept the 40% hub, 60% node budget with the numbers presented in Dr. Tomenga's slide as the outline budget, and the detail can be presented at future meetings.
Okay.
A second.
I have a second by Israel. Any further discussion? Hearing none, all in favor of the motion to have a 40-60 split of the dollars, with 40% going to the hub, 60% going to the nodes for this biennium, signify by saying aye.
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 Anyone that's opposed, say nay.
Nay.
Okay. Anybody abstain? Okay. So let the record show that we had one no vote and the rest were a yes vote for that 40-60 split. Okay. Is there anything else that we need to vote on the research budget in this full open meeting so everyone can participate? Anything else that we need to talk through on this?
Well, the only decision is left that was not finalized, and I don't know whether we need to vote on that, of reestablishing some kind of a representative research group that will help. Maybe not. So bearing in mind what Luann has said, that we cannot get into the issue of forum, but that will represent all or majority of the places and will constitute a subcommittee, which will bring the things toward the committee. My point is, and I'm assuming, although Michael and I will probably have different opinions on that because we voted differently, I'm thinking that Michael might have different ideas. And clearly what we had today was not sufficient opportunity to seriously discuss what are the alternatives. And it's quite possible that people consider that separately and so on. But in order to allow thoughtful discussion and input in the decision-making process. Do we want to establish that type of structure? So
Okay. It's a question, not a motion yet, as I understand.
Yes, it is a question, because I'm not sure that we need to decide it now, or is it good to decide it now if we want to do it?
Dr. Wakefield, I see your hand.
Yes, I think there's been a lot of great discussion regarding this today. My opinion would be that we gave quite a bit of information in the protocols and the plans and the goals of these studies to both the executive committee, to each of the nodes, the HRIs, and to the legislatures, and that we are not close to meeting those goals at this time. And as we've just voted to reallocate these funds to these projects for the next biennium, that discussion about future projects is a very important one, but premature, in my opinion, and that we can do this in the next, in a year from now, to have good planning and to reevaluate where these projects are. But to start having that discussion right now would be very premature, in my opinion.
Okay. Dr. Blader?
I think Sarah pretty much stole my thunder. I was going to agree in principle with what Israel was saying, but it's a little premature at this stage of the game. I would foresee, I think that to the extent that these are longitudinal studies, I think it's reasonable to say that given, the enormous strides that we've made standing up all these sites and terrific recruitment, what I perceive as great efficiency in getting the preliminary data organized and presentable. 2 years, I can't see things getting wrapped up meaningfully before then. At the same time, we need to define the endpoint of these projects. I think that I don't recall where the idea that I didn't see a power analysis that we need to have thousands and thousands of subjects, to justify it. Obviously, this can't go on for perpetuity. What's our endpoint? But I think we need to have a look at the data, see where we're at, and then start to put our heads together about a vision for what could be spun off from this as NIH or other funding, or what we've learned from this in terms of service delivery, and then to contemplate other areas of pressing need, whether they be psychosis, behavior disorders, developmental problems, and so forth. So I'm just endorsing the concept very strongly, but saying that at this stage of the game, it's premature to take action on it.
Okay. Dr. Nimrod?
Yeah, I think Israel's points are well taken, as are Joe's. I think fundamentally what I want everybody to think about is that we've established a research network infrastructure that's going to go on for the next couple of years in order to finish these projects. But we want that infrastructure to stay in the state for other projects, externally funded and internally funded by the legislature. Israel's exactly right that 18 months from now, we should be talking about whether there ought to be an ADHD or a perinatal psychiatry, but we would maintain infrastructure of the networks. So some funds should be set aside in the next biennium for the network maintenance as we figure out how that network will be used by all of us for extramurally funded projects. That's really what the vision has been. So I think I'm agreeing with both of you.
So how about Israel, in a kind of a good faith effort to meet what your real concerns are, and kind of where we are right now, that we put on the agenda in fall of this year a deeper dive into the discussion related to the long-term vision related to the overall research efforts, and have a significant amount of time blocked on the agenda in the full open meeting. So not another group, but in the full open meeting, we have that conversation. Israel, would that meet your needs?
Oh, absolutely. My question was when to start it, and I think that fall is early enough, and I don't have any problem with that.
All right.
I agree with that. I think I appreciate it.
All right. Well, thank you all for that that conversation.
Dr. Lakey?
Yes. Hey, Michael.
Sorry. Just to, first of all, I just want to thank you for having us go through this today, because that was one of my concerns, just to clarify that is where all the research money is going to go. And I think these networks are important. The two things we heard was that the networks were the vision, I think, from Dr. Martinez. And so I do agree with Charlie that we want to continue these networks over time. But I also hope that at some point we can also consider that a lot of this funding is going to studies within the networks, and those studies should have some kind of timeline and not just go on indefinitely. And the thousands of subjects is maybe not necessary to answer the questions in the study.
Yeah.
One last thing, I think, and this is my job as part of Dr. Trivedi's committee, I do want to try to help to make it possible for children with depression in our region to be in the study. Some of the way the study's designed makes it very difficult for our kids to participate, because the majority of them are not in clinics, but they're out there.
Yeah. So thank you, Michael. And I really do appreciate frank conversation here. And again, my goal was to have the frank conversation in the open, so that all of us had a fair component of that conversation. So thank you all for voicing your opinion and helping us to move forward. Dr. Trivedi, if you have another comment, it needs to be quick, because I need to move on to the other agenda items.
I think I just want to agree strongly with what Michael just said. The networks, and there is so many models in the country that we've done these, Michael. But the network itself is then the home for any investigator to do large studies. And so that can be anywhere. So you're exactly right. That model is best suited.
Okay. All right. Well, thank you, everyone. I'm going to jump back earlier in the agenda. And Julie Wayman is from the Texas Educational Agency. And sorry, Julie, I kind of jumped over you as I was reconfiguring things. And so I know this is a little bit later, probably quite a bit later than when you were expecting to present, but it really is great to have you part of this meeting today. Just double checking, I'm looking through, is she still with us right now?
Yes. I'm here, Dr. Lakey.
Oh, there you are, Julie. All right, thanks. Let me turn the virtual podium over to you, and thank you again for your patience as we've been juggling all the things today and people's schedules and everything else.
Well, I just want to thank you, Dr. Lakey. I just want to say this is one of the most amazing networks I've ever seen. I've been with TEA doing this kind of work since 2009, mostly for dropout prevention and some child welfare and court work. But what you guys are standing up and what you stood up just since 2019, I mean, we're not talking a big long history here for this group. And what I've seen from my vantage point over the past couple of years is just some amazing, amazing people and work coming together. And I am grateful on behalf of schools and children in our state that we work with, that y'all are doing what you're doing. I can say, I mean, I remember just before the pandemic when Dr. Wakefield and Dr. Vo got us together to start talking about some referral pathways, and we started doing some of that work and visioning, and remember meeting with Dr. Trivedi and certainly have worked with Eric Stork, Dr. Stork, for quite a while. And then later when Luann came on board, working with her and Dr. Williams, it's just been a constant increase of engagement as we see you go into the schools. You've come out and met with many of our rural schools and our networks at Education Service Centers. So I just want to say I'm grateful to begin with for that. But I'm just going to talk to you briefly. I'm going to try to keep it quick, keep my slides moving so I don't linger too long and move to the next slide. I'm just going to talk a little bit about our mental health initiatives and resources. I want to make sure you can ask any questions you might have, and then opportunities for collaboration. And just say that, this is kind of a tough act to follow after you're talking about all of this big research. And I'm really excited about the data that I got to see today that you're already turning out. It's very impressive. And Dr. Lakey got on the phone with myself and the director and some of us and some of y'all's people early in the pandemic. And it's like, what can we do? What can we start? How can we work together? And I just want to say it's been a great process so far. So 2 years, that's it, people. So alignment, we are aligning many of our mental health initiatives under this logo that you'll see. It's called AWARE. After Hurricane Harvey, the governor had stood up a task force on school mental health supports. And we worked with MMPHI and some folks from HUG and about 50 different nonprofits and other agencies to address mental health issues in schools in the Harvey impacted region. And through that, many of the organizations went out, and some of you all, and established more funding and of course grants, and a lot was happening. One of the things TEA did was apply to SAMHSA, and it's really our first mental health grant for the agency. We are an education agency. So we did apply for AWARE from SAMHSA, Advancing Wellness and Resiliency in Education. So since we were awarded that competitive contract, we've built out and are building out our mental health supports under that. So you'll see that. I wanted to tell you. We work to align with the Texas Behavioral Health Strategic Plan, as you do as well. We have many statutes now, as you know, since 86R, it really started up. We had a few before that for training, but we're continuing to try to scale that up. We have a strategic plan with a vision that the commissioner and the education system has for all students to be college, career, or military ready. And we work toward that through different measures and milestones for early reading and math and more college readiness measures along the way. So we're working to align our mental health supports with all of our program initiatives, education effectiveness frameworks. You might know ESSA's come out with, there's been some more funding that we've worked to align with to make sure that mental health supports are included in what districts can support. All of our special populations, you know all about this, and our stakeholders and providers. So it's important to us that we just continue to partner and build and teach school districts how they can use different partners and funding streams and make things happen together, just like you all are doing across all your HRIs. So next slide. And so I want to give a shout out to Sonia Gaines and to USAC. Back in, I guess, maybe in 15, 16, I don't know if she's still here, but she asked TEA to begin a network of unified services for all children, where it's a place for state agency staff from Juvenile Justice Department, HHSC, TIMH at UT, and others. And now Luann's joined us just so we can get together and network and support and coordinate some of our programs. It's been great. We're going to have our 5th summit this year for advancing behavioral health collaboration in schools, working with some of our small and rural LEAs that we're going to invite there, and we'll be rolling out some tools. And knock on wood, we'll have the commissioner there to kick us off. So just excited, and I want to acknowledge the important collaborative work that's going on in many spaces across our state. Next slide. And then one more thing I wanted to acknowledge in terms of capacity building that we use at TEA. In terms of, we have those interagency partners through the Behavioral Health Coordinating Council, USAC, and other vehicles, but also we have a mental and behavioral health professional learning community. We stood up with our education service centers, and we were doing that right in 2019 before the pandemic hit, and have done a lot of training through them and standing up school mental health and safety teams and trying to make this a place where they're ready to equip schools more. We did bring in Luann, and Dr. Williams came, and some other people came, and really did a lot of sharing about TChat and connected up some of our small and rural schools. I don't have data on that, but I know of a couple already that I'm working with that partnerships were created. So we want to keep that going. Next slide. So quickly, next slide. School mental health resources. So here's some of the things that we're putting out there, have put out there. Just we'll go through these just real quickly so you kind of see the lens that TEA puts on this. This is very different than a lot of your deep mental health therapy work that y'all are doing, which is great because that's not what we do in schools. Largely, we are prevention and we do early intervention, And we connect people up with resources such as yourself, and sometimes bring those resources into the schools where you can do some more reinforcement with the students and staff on supporting their mental health. So these relationships are important to us. Obviously, in the pandemic, we pivoted off all projects that we were working on, supporting schools in many different ways in hybrid learning. And this series called Project Restore is one of the commissioner's favorites that we've stood up. It has more hits for training than anything that I'm aware of during the pandemic, but you can see what's on there. You can see what the 6 modules are. These are 1-hour modules for educators to take and get CEUs for. And we feel that this has given them a wonderful insight into some basic training that they needed. Of course, it's statutory as well that they get trauma-informed care training. But during this time, this has been very well subscribed. We appreciate it, and we hope that our educators are more equipped now. And also I want to thank, we've networked in a lot of people to advise us on this, from HHSC, from TIMH, from some of your other agencies. So we appreciate all the advising and guidance that we had to develop this series, and I got the links on there. So you can go through the next couple slides. They're just in your deck in case you want more detail on it. I don't need to talk about it all, but it's just that we're really focusing on self-care and long-term behavior change of the adults. And so that we can support the students as well. So it breaks down the content. It's very digestible and easy to go through, and it allows for some didactic presentation, allows for group facilitation. Next slide, we have a facilitator guide that goes along with it, and educators can use CEUs. So if you ever, see someone you think could use some more training, this is one thing that we would really encourage. We have educators doing book studies on this and using it in groups in all kinds of different ways. Just going to flash through a couple things. I mean, we developed lots of resources over COVID while you were developing resources as well. One of the biggest subscribed resources for mental health was just this really nice, clean 4-page resource guide with just quick links for a desktop guide for our staff. And this is really important. And we got all the state links up there, and I believe y'all are in there. So we'll just keep on going. Next slide. Making sure immediately that schools were able to let TEA tell them that they can do remote counseling, they can do telecounseling, telehealth is a real thing. We made sure to put guidance out around that for support services right away during the pandemic. So this is several pages around that we shared with the schools for guidance for student support. Next page. And still relevant today is this Educator Wellness Strong Start guide that we put together when schools were starting to make sure. One of the things that we were hearing, I'm sure you all hear, educators have been stressed. It's been a very difficult 1.5 years or more. Everyone needs a break, and we provided some ways to support educators, to assess needs, to put conversations together. And I heard some of you talking about supporting some educators. And I would tell you that we really appreciate that whenever that's able to be offered to our educators. And we framed that within a multi-tiered system of support. We'd like schools to be able to think about how can we support the well-being of our educators so they're well and whole and can best serve our students. Next slide. So just real quickly, House Bill 18, you might remember, did several things for us at TEA. Supporting supports for mental health. It added some things, it deepened some of the things in the collaborative work that we do, as well as Senate Bill 11 did. So I'll just talk about that just for a minute on the next slide. I just want to give you guys some context of what is in the Texas Education Code. I just thought it might be helpful for you to see this. This is our grounding and foundation in terms of mental health for schools. And this list provides the main components that schools are required to develop policies and practices and protocols around these topics. And so we use this to help schools understand, and we develop resources and tools around these things with how these can be delivered, operationalized within a multi-tiered system of support. Of course, we are largely prevention, along with our early intervention, as I've said, and making sure our tier 1 supports are strong in our schools with positive youth development and skill building for our students and building that positive and safe school climate. and also that mental health promotion and prevention we do. We know that many of you are in schools doing programs. I know we have the YAM program and Dr. Trivedi does, and I know we have many others going on in the schools, and then connecting into that early intervention and through our referral pathways. So I just wanted you guys to see this was the base. This got transferred into the education code from the health and safety code, and it's really helped us to design training and supports for schools. Next slide. We have, when we first started this when the legislature passed it, I was telling you, like, you guys are new with what you're doing. I mean, this passed in 2015, that those resources, that TEA and HHSC would work on developing resources. We started it, we had a list, and now we have like 9 pages on a mental and behavioral health page. So it takes time to build things out. And we have a lot of resources that we vet and that we place on our website just for school districts to help them. And this is going to launch into another phase where we're going to build a new TEA, a Texas school mental health website that's going to house lots of resources and tools that we're very excited about. But we try to use this to make sure schools are aware of training requirements and resources available to them to support students and families in schools. Next slide. So we annually update this. We're going through that right now. We've been working since right before the pandemic, and Dr. Stork has worked with us on this. We work on a school mental health practice guidance toolkit. We have many, many tools in this toolkit. We've sent these tools out, we've piloted them, we've pressure tested them with school districts. A lot of work to do before we release something big. The 2 resources that are in there, a lot of them are out. On the next page, couple pages, I have some examples for you of some of the things that are in the toolkit. But basically, this is going to move to the next slide. This is going to provide educators with some guidance. And the slide right before that is the model of the domains that we're using. If you could just back up one slide. I just wanted everyone to see the comprehensive school mental health model that is taught to educators through the National Center for School Mental Health. We went to DC, we've met with them. I just met with them again the other day for some more training. Several of us did our Aware schools, because we're working, implementing this right now in Hurricane Harvey regions through our Project Aware Schools, where we've stood up and placed mental health professionals in schools and in regions. And I think we got TCHAT into one of those regions just recently, into those schools. But this is sort of how they structure, schools to set up these multi-tiered systems of support, right? With the teaming and the planning. Needs assessment, we're really trying to make sure schools are looking at mental health needs when they do their district improvement plans, campus improvement plans, blend in these mental health needs assessment and map your resources. We have early identification and screening tools that we worked on with the committee, building out this, and many of you researchers were involved with that. And then our tier 1 supports, schools are to do mental health promotion, prevention, staff wellness, and work on school climate, right? At the base. And then at tier 2 and 3, that's when we start connecting them up with you and other resources for early intervention, specialized services, referral, and access. And then we work with schools on funding and sustainability, measuring progress and outcomes. So these are some of the things that we do, and we have indicators for what quality school mental health looks like. They've been provided with 3 free tools through the National Center to just kind of measure for continuous quality improvement, because they are just getting started and they have a lot on their plate. Next slide. Just at a glance, I'm not going to go over these, but I just put it in your deck so you can see some of the different tools we have in our toolkit that are all up there. We'll be up there on our new website that we're going to post, that we're finishing up with Aware and our TIMH partners and HHSC partners, and for posting in a new format, and that will happen in July. Next slide. So as you can see, different transition plans, safety plans, wellness plans, sample MOUs, trauma-informed practices, things like that, that we'll just be giving them small doses and adding more as we go along. School climate surveys that we promote and work with schools on. Next slide. So quickly, Senate Bill 11, just to talk about kind of our part that we work in Senate Bill 11, strengthening school safety and mental health for us. It's been part of the work that we've been doing. On the next slide, we can just mention that our Safe and Supportive School program was an early piece of the work that at the high level, the Commissioner's Chief of Staff convened us early on. to look at this bill, to look at what had to do with emergency operations planning and facility safety in schools in terms of preparation and mitigation, and how we link mental health and trauma-informed supports into all that in suicide prevention. So we've identified these 6 pillars that are in that program. As you can see, the second one, the first one is promoting that positive school climate, which is at the base, and building that multi-tiered system of support for school mental health. And that's where we would build out all of our prevention supports, as well as our referral pathways to the resources in the community, like you all, build partnerships and learn how to make them better and stronger. And this is, some of you may have, and I'd love to know some more stories along the way, but conducting the behavioral threat assessment. So we work with the school safety center, of course. We meet every couple of weeks, and I'm bringing Luann to present to them, I think in the next couple of weeks, but we work on the behavioral threat assessment process. And I think some of you may be involved in some of the services through the referral pathway from a behavioral threat assessment. And we would appreciate that work as well, where those partnerships make sense in the schools that you're working with, to make sure any of our students who are receiving any kind of need, whether it's a behavior need the student has, or a student victim, or whatever kinds of work needs to be done. We also do a lot of dispute resolution in the schools, restorative practices, things like that. So we're promoting guidance, training, and awareness. And this is relatively new, and we pivoted for the pandemic, and we're continuing to build that out. The commissioner is so committed to this, he's fixing to build a division for safe and supportive schools. And so I can say over the pandemic, the needs of mental health, the awareness has been raised for all of us. And I appreciate deeply the commissioner's commitment to that. And we're working with our counseling department, which is really built up a lot in our student services, and Safe and Supportive Schools is building up. We're getting a lot of this integrated into our effective schools framework and planning. So it's all a good piece of work. Next slide. I just want to let you know, these are 10 modules. It's a course we're developing for school mental health multi-tiered system of supports for the SSSP program. For that multi-tiered system of support in those pillars. And these are 10 of the modules, the content that are in development right now. We'll be releasing the first 4 in the summer here soon, and then positive school climate as well before school comes back. And educator, yeah, probably number 6 too. So we'll be releasing most of these in the summer, iteratively kind of rolling, and then through the early fall. But just wanted to let you know that building this in an LMS, kind of like we have Project Restore, is our goal. So there'll be 1-hour modules that educators can take, and safe and supportive school team, multidisciplinary teams can take, just to affirm and teach them how this all fits into the overall education structure and the structure of building mental health and wellness and resiliency for all. Next slide. So one of the things Senate Bill 11 had us do was a regional inventory of mental health resources and a statewide one. We did develop a statewide resource guide, and Luann came even and presented with our regional service centers who are responsible to do this. TEA is charged with developing a template, getting it out to all 20 resources agencies. I think we have about 12 agencies working together on the template, the guidance, getting it together. So anyway, the ESCs have begun their first mapping. And this asset mapping process is new to our education service centers. Their role is instructional support largely. So we see this as a big win, because we have lots of feedback from our ESCs, how this has opened their eyes to many of you, and the needs and how it all connects, and identification of service providers. And we're beginning this again in December to do the second iteration. We're in the process of improving the tools. And at some point, we're going to want to build them into a database, just as we are those resources. There's a plan for that. The resources on the TA webpage. So it's iterative, but this will be our second time at it. Next slide. I think we had over 2,000 resources maybe identified, and we know it was a way of an undercount. Those resources needed to be included with the statewide plan for student mental health that the commissioner TEA needed to submit. So we prepared this plan, and it basically addresses the goals of the educators, of the legislature, for us to increase adequate access to mental health resources for students in schools. So we set some 5-year goals to work toward that. coordinate with the Safe and Supportive School Program, coordinate with our School Mental Health Task Force, link with all of our resources, including all of you all. So we're going to continue to work on that. It does set out some research we had done for us by Westat, and also regarding needs, and it lays out our multi-tiered system of support in there as well. So we see that as the first draft that we put out there during the pandemic to get us started, and look forward to working the plan. Next slide. And then finally, House Bill 906 created a school mental health task force. This task force on the next slide was created to study and evaluate and make recommendations to the legislature on school mental health support services supports. And so this task force was appointed by the commissioner. It has created its first report that was submitted in November. And basically it's just a lay of the land. What's out there generally, and what are some things, and just elevating the need to be escalating more resources into school mental health. And congratulations, we're so excited that you all are continue to be funded and continue to be serving students and schools and families. And I would expect this collaborative task force is going to do a deeper dive into some data with schools, some surveying of schools in terms of specifically, we didn't do that during the first year because of the pandemic. And we did not want to bombard schools with a lot of data collection early on. But at this point, I think that they'll be looking deeper into it. And they also would hope to promote the evaluation work that you're doing with TChat, and that we have great evaluation data from other services and supports that are in our state. Next slide. So just a shout out that we are going to have a Texas School Mental Health website, and we hope to link to all of you all. We see ourselves as promoters and connectors of the resources that are out there, and championing them and encouraging schools to link, and helping to problem solve whenever we can. And showcasing some spotlights where schools are doing things. You know, they love to see each other. Some of you, I hope we're going to have present in some panels in a school mental health conference that we're planning for next year. And maybe for a summit this year in September. Luann will be coordinating all that with me. And I just want to say, when we get that, I'm sure Luann will share that with you when the URL goes live, and it's time to get that word out. And so that's it. And I think on the next slide, it's just, if you have anything for me, let me know. Just happy to keep pushing out your information. Happy to see that you're expanding, developing, serving more students in schools. Love the data, love the data, love the data, the research. And I say, you know, if we can get kids better and functioning in school, hopefully you're measuring some of that along the way. That gets a lot of points as well, and we would appreciate that. And thank you for the work you're doing. If there's anything we can do to help, let me know. Thank you.
Thank you, Julie. It's great to have you here. Unfortunately, we aren't meeting in person, because it'd be great to have you at one of our meetings in person, and for our folks to get to know you and everything else. But thanks for all the work you're doing and all the support for the consortium. We have a little bit of time if folks have any questions for Julie. Please just go ahead and raise your hand. Steve Pliska?
I was just curious, will we be able to, how long will we be able to continue the Zoom meetings? Is there a point at which we have to revert back to in-person? I mean, I'm not advocating it, I'm just thinking for future planning.
Yeah. So we were given additional, leniency, or whatever the right word is, because of the event, with COVID. But our plan is to try to come back together probably this fall, and then start to have some mixture of in-person and out and virtual. Luann, you raised your hand.
Yes, I was first going to thank you so much, Julie. As all of you can see as consortium members, there is a lot of crossover where the consortium's work and the work of the Texas Education Agency, specific to integrating children's mental health and the education system. There are so many opportunities for us to work together to enhance each other's work and not duplicate each other's work. And just for example, some of the meetings that Julie's been involved in with some of our team have to do with things like Laurel, Dr. Williams presented earlier about WellNitty, and how there's a creation of mental health resources through WellNitty. And we've talked to Julie about the possibility, as she mentioned, of the resources being identified through TEA, and how can we merge those efforts so that we're not duplicating again, and trying to search out resources, but really enhancing that work. Other areas we've talked about just preliminarily is if there's a possibility that educators might be interested in some sort of an ECHO type format where some of our HRIs could participate and provide information to educators about specific topics relating to children's mental health. So there's just lots of opportunities for us to work together, and I'm just excited. I know all of you probably have ideas as well, and we just want to keep the partnership going with TEA. They're a crucial partner, because kids are in schools. And so we have to be able to work effectively with TEA and with our local school campuses and districts. So I just wanted to mention that and thank Julie a lot for being here today.
Thank you, Luann, and absolutely. And along the way, as we do, you develop and we do continuous quality improvement. If you see some features, and as you do, and as you surface and you talk in your groups, where we might be able to do something better to support you and to support schools, or something that you're seeing within, we're really trying to build out the thinking around good referral pathways and follow up with our students as well. So if there's any discussion we ever need to have around that, we're certainly, willing to do that, and we can blend any, tools or resources or messaging in there that can just help people understand better, help support our counselors. And Luann and I have talked about all kinds of training that you all can do. We want to promote that training that you're going to do and get that out there so that people know. And I'd love to get some of your successes and data out there whenever you get that nice one pager together about how many schools you're in, and, and all that good stuff. But I know there's stuff in there. So whatever it is, we appreciate just to keep, educators, they like to see what another school is doing. And it's like, oh, they're doing that, maybe I want to do that. And so we need to keep those networks going and those shared experiences about the successes, because that helps keep your momentum going in the education field and how some of these things are done and that kind of thing. So, okay. Dr. Wakefield, there you are. Worked with you on the early committee.
Yeah, how are you?
Okay.
Lots of good work being done. Well, I just wanted to share with you that we have, since we last talked, we are doing our T-Chat and Cater initiatives in 87 ISDs, mostly rural. And we are providing ECHO services to all of those ISDs, teachers, administrators, and counselors, and have developed a curriculum for that, and doing shared presentations to our regional education service centers. I'm actually hopping off in just a second to participate in one of those. And so we're happy to collaborate. We try as much as possible to utilize the TA resources and present those to make sure everyone in the school systems are aware of all of the amazing resources that you guys have developed.
Oh, that is super. And so like as they keep getting more things, it just sort of supports the foundation, right, for all these to do. We're not doing the mental health work. We're supporting foundational development and networking. So I'd like to be able to promote some of your stuff over time. Maybe we'll get you on our new website to showcase some of this. So we can do some spotlights. Let's do some spotlights on T-Chat. Thank you for sharing, Dr. Wakefield. That is amazing.
My pleasure. It's a great collaboration.
Okay, well, thank you. I know you have a lot on your plate, and this was quite a divergence from your work. So thanks.
One second. Looks like Beverly Bryant.
Oh,
did you just, Dr. Bryant? Did you just raise your hand?
No, I am so sorry. I was trying to make sure my hand was not raised. I apologize.
All right, anybody else? I heard from somebody from Dr. Trivedi's office just today, and here and there we communicate here and there with different people, and so keep it going, and look forward to working with y'all. Bye-bye.
Very good. Yeah, look forward to when we can have a meeting in person and you can be there and meet everyone. Okay.
Absolutely, that'd be lovely. Thank you.
All right, thank you. So we have just one more order of business, and I believe, and Luann, correct me if I've skipped over something, but the one order of business that we have is to make a few edits and reconfirm our governance plan. And so everyone should have been sent out a copy of the governance plans. And I asked Luann to go through this. Now, I think it's important for us every 2 years to review the governance document. Most of the changes that we put in place are minor editorial type items. Luann has put it up. I guess the substantial change that we put in place would be at the end and reports to the legislature, and that, you know, in our reading of the writer that now guides us, that if you go back 2 sessions ago, we were required to put down a strategic plan that would be sent to the LBB and approved. That is no longer there in the writer. Instead, we're still required to do the biennial report, but we took out the paragraph related to the strategic plan and reporting that to the LBB. All the other edits that we put in place are mostly just minor. There's some additional information related to the statewide committees that our folks will need to participate in, or will need somebody to participate in. And then we have conflict of interest documents that are attached to this document. But first, kind of checking with folks, have you had a chance to look through this, and any comments? And if there isn't any comments or any additions, at some point I'm going to need to have a motion to approve the edits related to this. On the other hand, if you have something substantial that we need to add to it, we're open to that. We just, again, want to make sure that it's it reflects your will. Luann, is there anything else you want to say about it?
No, most of these are just, as you mentioned, tiny edits that have to do with just, you know, using acronyms, et cetera. And then the other one has to do with, if you scroll down to the part about the strategic plan, we've eliminated that section, as you mentioned. And then, you know, added the stuff about statewide, serving on statewide. One of the things we did add was that if you are a member of a statewide committee and you're a member on behalf of the consortium, that there may be opportunities in the future to present information about the proceedings of those committees to the full consortium, so that everybody's aware of what happened during those meetings that you represented. There's where the strategic plan was eliminated. Otherwise, it's just, you know, basic edits. And then, of course, adding the conflict of interest statement.
Move approval.
I have a motion for approval, from a second from Dr. Casse. Any further discussion? Hearing none, all in favor of approving this document with the edits that have been put in place, signify by saying aye.
Aye. We have some discussion. We might have some discussion.
You have some discussion?
I think.
Was there any discussion? Hearing no,
sorry.
Hearing no discussion, all in favor, signify by saying aye.
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 All right.
Opposed, nay. Anybody abstain? So to actually put the document back up and go to the section on presiding officer. So this has been approved. And I want to call your attention to the section on presiding officer. Okay. Go down. I think it's right below that. Okay. So one, yeah, keep it right there. The second line, the term of service for the presiding officer will be 2 years, but is renewable upon the approval of the executive committee. I currently serve as a presiding officer, and I have served for 2 years. If there's any other members of the executive committee that would like to serve as a presiding officer, you're fully eligible to put your name in, and would request that if you have a nominee to be the presiding officer, that you give that to Luann Southern. She'll keep that separate from me. But again, want to follow the rules of our governance committee, and any member of the executive committee can put their name in to be voted by the the consortium to be the presiding officer. And so again, just want to make sure you're aware of that. We will need to have a vote at our next executive committee on the presiding officer and moving forward. And so again, making sure that we're doing the bureaucracy, so to speak, and the governance according to the plan. Want to make sure that we do that in accordance with our governance plan. Does that make sense? So please if you have any nominees, please feel free to give them to Luann. With that, Luann, is there any other business for the consortium?
The only bit of business that's on there has to do with anyone who is interested in serving on the statewide behavioral health subcommittee. Get me your name as well, and the executive committee can vote on that individual's participation also at our next meeting.
Okay. So we're going to have an important meeting next time. Again, we need to finalize the budgets to get them to you in time to get through the system. We talked about the data group and trying to finalize the data governance. And again, would need to, if there's other individuals that would be interested in being the presiding officer, we will need to make sure that we do that selection and select who would represent us at these other committees. Any further discussion from anybody else? That's, again, trying to make sure we're germane to the items that are listed on the agenda, but any other items from the executive committee that we haven't finished that are on the agenda? Hearing none. Somebody could make a motion to adjourn this meeting and give you back 30 minutes if you are so inclined. And everybody makes the motion. So I have a motion by Dr. Ibrahim, a second, I think, by Dr. Chessay. That's as best as I could tell. So with that, we are adjourned. Thank you very much. Have a happy Father's Day, Juneteenth, etc. weekend, and we'll talk to you soon. Thank you.
Thank you.
Thank you.